This conference will now be recorded.
So this is the ANCAN Advanced Recurrent High-Risk Prostate Cancer Support Group special session where Len Sierra, that's me, and Herb Geller will be presenting the summary of the June ASCO annual meeting. And I'm going to start and run through my slides.
Len, first, I would like to say, and I think Len and I both agree, that you're going to hear the presentations that we consider the most interesting, but we didn't think overall this was such a great, interesting meeting for us. That the work that was, they have a special GU meeting, which Len and I presented earlier this year. And I thought there was much more interesting material at that meeting. So that's our sort of preamble.
Yes. Okay, so the first presentation that I'll be delivering, is there a way I can move these guys out of here so I can see the full top line, Herb?
I can see your whole screen. I can see your whole screen.
Oh, okay. All right. So the title of this presentation was ARC-6. ARC, A-R-C, means it's coming from Arcus Biosciences. So it's ARC-6, a phase 1b/2 open label randomized platform study of efficacy and safety of, and I hope I'm pronouncing this right, etrumadenant-based treatment combinations in patients with mCRPC. If I say mCRPC throughout this presentation, everybody knows what I'm talking about? Yes? If not, let me know. All right. So etrumadenant is an orally available small molecule, which is a dual adenosine receptor antagonist being developed by Arcus. As Herb and I recently learned after reading a paper co-authored by Larry Fong on overcoming resistance mechanisms to checkpoint inhibitors, we learned that one of the avenues they're exploring is adenosine receptor inhibitors. Because elevated levels of adenosine in the tumor microenvironment can impair T cell function. And remember, guys, that T cells are the T lymphocytes. They represent the body's cellular immune system, and they seek out and destroy cancer cells. Elevated levels of adenosine in the tumor microenvironment can impair the T cell function, and it's believed to be a mechanism of resistance, as I just mentioned, to immune checkpoint inhibitors. All eligible patients in this study have mCRPC that has progressed on androgen deprivation therapy, and none of them have taken either a checkpoint inhibitor or a taxane. So these are the initial results from we're shortening etrumadenant, thank God, to etruma plus zimberelimab, which is the checkpoint inhibitor. It's an anti-PD-1 monoclonal antibody, plus Dosatexel, D. So make it nice and easy. This combination is going to be referred to as EZD. Here are the results. So the median time on this triple regimen of EZD for all 14 evaluable patients was 9.9 weeks, so just about 2.5 months. In response evaluable patients, the PSA response rate was 36%. And remember, PSA response typically means a PSA decline of 50% or greater. So the PSA response rate was 36%, 5 of the 14 patients. The radiographic response rate was 38%, 3 of 8 with 1 complete response, and the composite response rate, meaning the PSA response rate plus the radiographic response rate, was 43%, 6 of 14. The most common, this is treatment emergent adverse events. Just think of it as adverse events, make it simple. So the most common adverse event, which was greater than 30%, were lymphocyte count decreases and neutrophil count decreases. That's not too bad if in the way of adverse events. And hyponatremia, which is low blood sodium levels, and alopecia, 35%. Grade 3 adverse events were reported by 53%. That's a bit on the high side. Grade 3, it often requires some form of intervention that requires the patient be in the hospital. So the conclusions are that the phase 1b results indicate that the EZD treatment in patients with mCRPC had a manageable safety profile and was associated with clinical benefit. So having met the phase 2 advancement criteria, randomized patient enrollment to this new regimen of EZD will be run against Dosatexel alone. So phase 2 will be etrumadenant Z, which was the checkpoint inhibitor, plus Dosatexel. That'll be one arm, and the other arm will be just Dosatexel alone. So we'll see what is the contribution of the adenosine receptor antagonist etrumadenant and the checkpoint inhibitor.
Len, can I just say one quick thing?
Right ahead.
If anybody has any questions, I would encourage you to put them in the chat box, and then we'll try and get at the end of the session when Len and Herb have both finished presenting, we'll try and get through as many of the questions as we can, time permitting. So the chat box is the little bubble in the top right-hand corner. Just put your questions in the chat box. We'll go through them later.
So, I mean, my take on this one is that, you know, the role of adenosine and blocking of adenosine is still a potential approach, and this trial sort of indicates that it may be coming along.
Yeah, it's kind of promising. All right, the next study is a first-in-human study. This is phase 1 of TAS-3681, which is an oral androgen receptor antagonist. You know, that puts it in the class of enzalutamide or apalutamide or darolutamide. And in the patients, these were the first phase 1 patients had either androgen receptor, well, hold on, let me back up and just say that the hypothesis is that this new oral androgen receptor antagonist downregulates androgen receptor number and androgen receptor splice variant activity in patients with mCRPC that have failed ABI or enzalutamide and chemotherapy. So this is a pretty heavily pretreated population. They're resistant to hormone therapy and they're resistant to chemotherapy. Here you have patients had a median of 6 prior lines of systemic therapy. That's pretty high. So all patients received this new androgen receptor antagonist in a 3x3 dose escalation design, QD, or that's once a day, or BID twice a day tablets were given in 28-day cycles. The primary endpoints were, and don't forget this is phase 1, so we're assessing safety above all, and pharmacokinetics. So the dose limiting toxicities and adverse events were the primary endpoints to be measured. and other endpoints include pharmacokinetics, which means how the body metabolizes the drug. And a bonus would be some nice anti-tumor activity. So the results are confirmed PSA declines of greater than 50% from baseline were seen in 22% in the 300 milligram twice a day cohort. Which represented one confirmed partial response and one unconfirmed complete response in a total of 9 dosed patients. Very small trial. Responses occurred after 2 to 4 cycles of treatment, and remember each cycle is 28 days. So basically this is 2 to 4 months responses occurred. The longest duration of response to date is 16 months. 300 milligrams twice a day was found to be the best tolerated dose with anti-tumor activity. 3 patients had dose-limiting toxicities. 2 of them had QT prolongation, which is a cardiac effect, and 1 had grade 3 hypertension. Grade 3 hypertension would be 160 over 100 up to 180 over 120. Most common adverse events were nausea. This I found a little upsetting to see that more than half of the patients had nausea. Hyperbilirubinemia, which we see elevated in cases where there's some form of liver toxicity going on. Fatigue in only 32% of patients, so that's not so bad for an androgen receptor blocker. Now, also vomiting in 30%, I found that a little bit disconcerting, and diarrhea in a little more than a quarter. So the conclusions are that the recommended phase 2 dose going forward will be the 300 milligrams twice a day. The investigators feel that this is a manageable safety profile and has anti-tumor activity against heavily pretreated, multi-drug resistant patients with mCRPC. Okay. Herb, do you want to comment at all, or just should I move along?
Well, I mean, I thought if you go back, Glenn, I think I go back to me, 16.2 months for this group of patients. That's pretty remarkable.
Yes, I agree.
So, I mean, yes, the toxicities are really gastric and nausea, vomiting, diarrhea, and bilirubinemia, which is, again, I mean, that's common for these enzyme inhibitors. So, you know, who knows? Again, let's see what happens in the next phase.
Yeah, this is one to keep an eye on for sure. Okay, the next study is a phase 1b/2 study of ribociclib in combination with docetaxel plus prednisone. And again, the patient population is mCRPC. So for background, ribociclib is a selective cyclin-dependent kinase inhibitor, CDK inhibitor, a class of drugs that help slow the progression of cancer by inhibiting 2 proteins called CDK4 and CDK6. These proteins, when overactivated, can enable cancer cells to grow and divide too quickly. So the good news here is that ribociclib was already approved by the US FDA in March of 2017 as Kisqali, if I'm pronouncing that right, for certain types of metastatic breast cancer. CDK4 and 6 inhibitors, such as ribociclib, have shown synergistic activity with taxanes in preclinical cancer models. Those are animal models and prostate cancer cell studies. So investigators sought to determine the safety and efficacy of ribociclib plus docetaxel plus prednisone in mCRPC patients. So patient selection and results. Patients were treated with escalating doses of ribociclib in combination with docetaxel and prednisone for 6 to 9 cycles, followed by single agent maintenance ribociclib until radiographic or clinical progression of disease. 30 patients were treated at the recommended phase 2 dose of docetaxel 60 milligrams per square meter on day 1 and ribociclib daily on days 1 through 4 and 8 through 15 of the cycle, with daily GCSF support on days 5 through 7. Those are things, GCSF boost your bone marrow, your white blood cells, Neulasta, drugs like that. The median number of docetaxel cycles was 8.5, and 60% went on to receive maintenance ribociclib. So in other words, after the docetaxel was cycles finished, patients would continue on just ribociclib for maintenance. Phase 2 primary endpoint was met with a 6-month radiographic progression-free survival rate of 65%. That's pretty darn good. Median rPFS was 8 months, so half above 8 months, half below. The PSA response rate, defined as greater than 50% reduction in PSA, was a little over 1 in 4 patients, 27%. And the objective response rate was 30.8%. Presumably objective response rate meaning radiographic measurement. Among patients treated at the recommended phase 2 dose, the most common grade 3 or higher treatment-related adverse events were neutropenia, 36%, and lymphocytopenia. So that's a reduction in white cells and a reduction in lymphocytes at 10%. That's not bad at all. So conclusions: combination of ribociclib plus docetaxel was well tolerated and showed promising activity in MCRPC patients who had progressed on RC is androgen receptor selective inhibitors, things like enzalutamide, apalutamide, AbbVie, etc. Phase 2 study met its primary endpoint with encouraging 6 months rPFS rate of 65%. They were targeting 55% and they got 65%. So that's why they're moving on with this. It was very good. This was interesting. They did a biomarker analysis and noticed that if the CTC, the circulating tumor cells that were sequenced, did not have the mutations MYC or CDK6 amplification, then that was associated with longer radiographic progression-free survival. So I don't know, maybe in the future they might screen patients for MYC and CDK6 on the CTC cells. All right. Next study is radiographic progression-free survival as a surrogate endpoint of overall survival in men with metastatic castrate-resistant prostate cancer. So as we all know, rPFS is often presumed to be a surrogate for overall survival in clinical trials. The knock on prostate cancer is that, well, you know, these guys, they live pretty long. We can't run the trial for 10 months. I'm getting feedback from someone on my own voice here. But you know, it's never actually been validated as a surrogate endpoint for overall survival. So the investigators hypothesized that it is a reliable surrogate for overall survival. They performed, now this is what we call a meta-analysis. It's not a clinical study, it's just a review of past clinical trials. Investigators performed a systematic search of the literature encompassing the period of 16 years between 2004 and 2020 using PubMed and clinicaltrials.gov to identify appropriate completed phase 3 trials in MCRPC patients post-Dosatexel. It was pre-specified that radiographic progression-free survival would be considered a valid surrogate for overall survival if the correlation between the two was 0.7 or higher. And Herb, you can correct me if I'm wrong on this, but I presume that means at least a 70% correlation between the two. Maybe we need to ask your wife about that one. So the results in 18 trials that were reviewed in the literature, almost 17,000 patients, where rPFS was considered as a key endpoint. A moderate correlation between the treatment effects of rPFS and overall survival was observed at the trial level. With the correlation, what they mean by moderate correlation is here, 65% correlation. Now, the conclusions from the investigators is that this meta-analysis demonstrates moderate correlation in patients with MCRPC. However, the rPFS did not meet the pre-specified surrogacy threshold of 0.7. So it's not a perfect surrogate, but I guess it's the best we have so far.
Well, but is it a good is this a surrogate? Do we really need surrogates? I mean, this is the point is we're looking at drugs and we're thinking they're great, all about these surrogate markers, but they don't have a great correlation with overall survival.
Right.
And so one wonders if the rPFS should be used. And maybe trials just have to go longer before a drug gets approved.
Yeah, but that means patients could have to wait 10 years or more for a drug to be approved.
True.
So until we come up with a better surrogate, I guess we're going to be stuck with that one.
Mm-hmm.
Okay, this is my last study before we get to Herb's, and this is a tough one. It's complicated, so strap in and pay attention. This is a phase 3 trial with 2x2 factorial design of abiraterone, which is Zytiga, plus prednisone, of course, and or local radiotherapy in men with de novo metastatic castrate-sensitive now prostate cancer. This is the first results of what they're calling the PEACE-1 trial. So these are patients who were diagnosed as metastatic right out of the gate. Just so we understand, a factorial design, factorial clinical trials test the effect of 2 or more treatments. And in this case, those 2 are ABI and local radiotherapy. Those are the 2 treatments. Let's see. So they're testing the effect of these 2 treatments simultaneously using various combinations of the treatments. The simplest factorial design, which is what we have here, is known as a 2x2 factorial design, whereby the participants are randomly allocated to one of 4 combinations of the 2 interventions, A and B, for instance. And A would be, let's say, abiraterone, B could be radiotherapy. So this design allows the investigators to compare the experimental interventions with the control. Now, the control in this trial was standard of care. Here's where it gets complicated, because the standard of care changed during the trial. First, it was just ADT alone, but then after, and we'll see this in another slide, after Stampede, it was determined that standard of care should, for these people, should be ADT plus Dosatexel for de novo and metastatic castrate-sensitive prostate cancer. Okay, so arm 1 was ABI and prednisone plus standard of care. Arm B, local radiation therapy. and the combo arm was ABI plus radiation therapy plus standard of care. So here's what I was talking about before. So the standard of care was initially just ADT. Then from October 2015 onwards, the use of docetaxel was authorized as part of the standard of care at the investigator's discretion until 2017. Then following the publication of Latitude and Stampede trials, accrual was restricted to men receiving ADT plus docetaxel. So that became the new standard of care. The trial has two co-primary endpoints of radiographic progression-free survival and overall survival. The median follow for this trial was 3.5 years. And the results, so from November 2013 to December 2018, 1173 men were enrolled. So standard of care was ADT plus docetaxel in 710 of those patients and ADT alone in 463 of those patients. Radiographic progression-free survival was significantly improved in the abiraterone arm in the overall population. Hazard ratio 54, which is like 40% reduction in risk. And that's a really significant p-value there, very, very low. So the medians were 2.2 years versus 4.5 years. And in the ADT plus docetaxel population, they're very similar. Hazard ratio 0.50, so 50% reduction in risk. And again, medians 2 years versus 4.5 years. Very similar, as you can see there. Let's see, the biochemical progression-free survival includes PSA progression as an event. Also significantly favored abiraterone in the overall population. Anytime you hear in this presentation overall population, that means the standard of care for both patients who are just getting ADT or those who are getting ADT plus docetaxel. That's the overall population. And hazard ratio or risk reduction, hazard ratio 0.4, risk reduction 60%. And medians 1.5 versus 3.8 years. And in the ADT plus docetaxel population alone, that standard of care was only ADT plus docetaxel population, you see similar results. The overall survival is still maturing. It's not ready yet. And here's the problem. Here's the problem, Herb. You see, this trial would still have no results if we're waiting for overall survival. Okay, so the investigators' conclusions. Adding abiraterone to ADT plus docetaxel significantly improves rPFS in men with de novo mCRPC with about 2.5 years of absolute benefit in the medians and no meaningful additional short-term toxicity. The investigators concluded that by adding ABI to ADT plus docetaxel is a potential new standard of care for patients with castrate-sensitive prostate cancer. Now, the table in the next slide casts doubt on the contribution of docetaxel, in my opinion, and I think Herb's as well, and also I think Herb, you mentioned Oliver Sartor commented on this as well.
Right.
So we're wondering, like, well, what's the contribution of docetaxel here? Because here you can see that abiraterone plus standard of care, plus or minus radiotherapy, median clinical progression-free survival is 4.3 years. Now, in the clinical progression-free survival in ADT plus docetaxel population, the median clinical PFS is 4.1 years. So it seems there's a slight advantage there for omitting docetaxel.
Yeah, I think this needs more. This to me, while it was heavily touted as a triple threat, ADT, docetaxel, and ABI, I'm not so sure about the conclusion. I think we really need to wonder about whether docetaxel is adding anything to this regimen.
Yeah. Oh, okay. So that's the end of my presentation. Herb, should we let
Yeah,
you
I
share?
need to, yes, I need to figure out how to share
Okay.
now. Okay, screen, if you stop,
Yep.
and then screen,
I just made you the presenter, Herb. So you should be able to do it now.
open system preferences, screen. What, I need to open system preferences? How do I'm sorry, Jake,
You should be able to just
Where-
do select share screen.
all right, I'm clicking on, it says GoToMeeting needs to use accessibility features, and it's not letting, I'm doing everything it tells me to do, but it doesn't allow me to share the screen. It says open system preferences. I'm sorry, guys.
Herb, I can run your slides if you want. You just tell me when to advance.
Well, okay, we can do that. I mean, there are some animations. They should work just for you. That'll be fine, Len. If you can do that, let's not waste any more time trying to debug my machine.
Okay, so Jake, I guess you got to switch it back to me.
Done. Go ahead.
Thank you. All right, let me get to the top.
Okay. Next slide, please. Right. Okay, we go right to the top.
Going to the top. Okay, here we go.
Okay. My presentations are really going to center on immunotherapy and what I think are some interesting aspects of immunotherapy. One is this BITE, where it's actually a tri-specific antibody, HPN 424, in a phase 1/2 trial of and it's a PSMA targeting T-cell engager, and it's with metastatic castrate-resistant prostate cancer. And I think if you notice, for those of you, the authors, many of our friends are here as authors. We have Mark Stein, De Bono, Larry Fong, all participated in this. So next slide, please.
Oh. Okay.
Right. So here's the background. So here's oh, you can't see my cursor, so I'm sorry. But on the left, you can see a figure of the idea that we have the cancer cell in red, we have the T cell in green, and HPN 424 in the middle, which has 3 parts to it. In green, you'll see it has an anti-CD3 label antibody, which then would engage the T cell. It has an anti-albumin in part, which basically lengthens the lifetime in serum, and then it has PSMA part. And then so the idea is to bring, this is what theory of all the bites, bring the T cell next to the cancer cell. It's a small globular protein for enabling penetration, and it binds to CD3, and right. So therefore, it's designed to increase the therapeutic index. Therapeutic index means the ratio between good effects and bad effects. So supposedly it minimizes the bad effects, which are called off-target toxicities, using this tripartite scheme. Next slide, please. Okay, so here's the trial design, and it's basically dose escalation. They have a fixed and a step dosing, and then they finally get to the maximum tolerated dose. And then notice that they said 20 patients were treated at the maximum tolerated or recommended phase 2 dosing part 1. So, and notice that the population had to have disease progression and castration-resistant disease, at least 2 prior therapies, so not quite 6, and then prior chemotherapy allowed but not required. And then they gave you the trial design and what they were going to look at: pharmacokinetics, safety and tumor assessments at 9 weeks and included conventional CT and bone scans and PSA. Next slide, please. And here's what happened. These are the plot of the time on treatment. Notice that some have gone to 110 weeks with a P, and then they indicate in this plot how long they've been on treatment. The arrows indicate that they're still on treatment, and then in red, some of the patients, actually it said 47% remained on treatment beyond 24 weeks, and 6 of 20 with greater than 1 PSA value showed PSA declines, including 3 PSA 50 and 1 PSA 30, and that's indicated PSA 50 and PSA 30 on the chart. So it's, and then a number of patients, we notice it said CTC 0, and that means that there was a big reduction in circulating tumor cells in these patients. So there are some effects. Next, please. And then here's a plot of the PSA values. Now, one thing you notice is that it only said 15 of 74 had PSA decreases. So that's in red, and the ones that went up are in gray. So yeah, I mean, again, it's sort of the people who responded, the guys who responded, and that's wonderful. But overall, it looks like not that, only about 20% responded. Next slide, please. And then here's the circulating tumor cell response in this waterfall plot. Some of them went up and some of them went down. So again, it said 54% had a greater than 30% CTC reduction from baseline. And then so again, this is, and it's 56% had, and 14 patients had CTC 0 response. So that CTC 0, they only went down to minus 100% notice in both at best and at week 13. So again, this drug has decent clinical potential. Next slide. And then so the summary, and I'll skip the summary. So the summary basically is active and generally tolerated, has anti-tumor activity, and treatment duration observed 24 weeks in 20% of patients. CRS, which is cytokine release syndrome, which is found with a lot of T-cell engagers, was transient and manageable with 4%, which is very small, having grade 3. And then it's basically, they're doing assessment of optical target dose in patient population for expansion. So I would look to HPN 424 for the future, and we'll hear more about it. Next slide, please. Okay, so this was an issue about when you have a mutation in your germline and whether you have a mutation in your tumor, where do you look to assess where the mutation is? Can you really just look at the tumor, or can you look at at metastases? Are they different than the primary tumor? And this is actually it was a poster, but I've now excerpted the data from their paper, which came out at the same time. And basically, it says that there's a high concordance of mutations in prostate cancer samples, which is the biopsy samples, and metastatic tissue or cell-free DNA. And the next slide, please. Right, the key points: can the mutational status of DNA repair genes in prostate cancer be assessed by just looking at primary and not the metastases? And the answer is in this association, basically gene alterations in DNA repair genes in cell-free circulating DNA or metastatic tissue were concordant. And that means you can use archived prostate tissue. You don't have to go and take new samples at the metastases to look for DNA mutational status. Next slide, please. I think this is some of the data. Oh no, this is the next poster. So back, Len. Back, okay. So this is All
There
right.
you
This
go.
was an interesting poster by Larry Fong. And it basically is what they're asking was originally, it was a trial of adding CTLA4 blockade with ipilimumab following CYP treatment to assess whether the prior CYP treatment would enhance the response to this checkpoint blockade. And that was their trial, right? And then they talk about CYP being the primary endpoint would be the patients who achieved an antibody titer for CYP, which is at PAP, clinical response, and a B cell response. And if you hit the key, Len, I hope it should work. I hope the animation works. Next,
What do I hit?
hit the key. Just move on, and let's see what happens.
Oh,
Yes,
okay. Nice.
Okay, so that's the whole point. It was originally designed to do this, whether you can add CTLA4 blockade along with CYP. Next, you can hit the key. And here's the results. And this, I mean, I don't have a pointer, but on the
Can you guys
left
see my
two,
pointer? Can they see mine?
yeah, yes, your point. So the
Where do you
left
want?
two survival, the left two Kaplan-Meier plots are what they were looking for. And basically, it said that ipilimumab did not significantly alter anything like progression-free survival or overall survival after CYP. So they decided that those, I mean, there's no statistical difference between those survival plots. However, on the right, which was something which was not part of their original design, basically shows that prior radiation, that they picked out that prior radiation of the tumor actually improved progression-free survival. So I think this was, they were looking for one thing, and then when they analyzed their data, they found out, wait a minute, we got something else here. That basically the clinical response was enhanced in the with CYP and ipilimumab if you had prior radiation. And I thought that was a pretty interesting observation, because this is sort of an idea that's been absolutely, the whole idea that whether there's an abscopal effect, whether radiating the tumor sort of energizes the immune system, and this might actually provide some data that it does. So that's why I thought this paper, even though it didn't achieve its goal of adding IPI to CYP making a difference, the radiation part, and of course that's why they put it in their title. Next slide, please.
Herb, we should make sure people understand that CYP is Provenge. Some people
Right,
may not
okay.
understand that.
Okay, as a former pharmacology professor, I don't use trade names. Okay, in general, yes, but CYP is Provenge.
And Herb, someone asked what type of radiation was that part of this study?
I don't think they said.
Okay.
I mean, it just said, all they say, lower frequencies of CTLA4 positive T cells was associated with prior radiation therapy. I think because it wasn't part of their trial design.
Yeah.
So I
think,
don't know.
As you said, abscopal effect possibly explaining some of what's going on here, because when radiation kills tumor cells, it releases tumor antigens into the blood, and that helps any immune response. And we've got two immune agents here, CYP or Provenge and IPI. So yeah, this kind of makes sense.
So, okay, next slide, please. Right, and that's sort of, here's the conclusions. Pre-existing immunity may help dictate response to IPI and CYP combination. Prior radiation therapy seems to leave a lasting impression on the T cell compartment and associate with improved clinical outcomes. So I do think that's This needs more attention, is what I would say. Next, please. Okay, so here is my last presentation. This is a vaccine. So this was their first human phase 1 study of PF 06753-512, a vaccine-based immunotherapy in non-metastatic, hormone-sensitive, biochemical relapse and metastatic castration-resistant prostate cancer. And this is a bunch of people originally, mostly at a memorial. So that's where this comes from. Next slide, please. So the background, obviously, they talk about prostate cancer as a series of clinical states, which we all know, and then the optimal disease state for immunotherapy when we give immunotherapy is certainly unknown right now, right? And it said therapeutic vaccines that target PC-associated antigens are an approach to combination with immune checkpoint inhibitors. So they've invented a vaccine-based immunotherapy as an anti-cancer immunotherapy that is in development for all the distinct clinical states of prostate cancer. And obviously, if this works early, you can avoid androgen deprivation. So that's the background. Next slide, please. So what is the study design? It was an open labeled study. So that means it's not blinded or anything. And what is this vaccine? Okay, that's the question that I asked and I had to dig around. But first of all, it's a priming immunization. So it's you get an immunization with what's called a replication deficient adenovirus vector. So an adenovirus vector can target several different cells. And the thing about basically what it's key here is that it's replication deficient. And a replication deficient virus is not like SARS, CoV-2. It basically means once it gets inside a cell, it delivers its contents and then it can't replicate. So it can't cause an infection. And then, so what does it have in it? It has 3 selected antigens, PSMA, PSA, and PSCA. And that you get intramuscularly as your first shot. Then you get a booster vaccine with the same 3 antigens. And then this is administered IM with an electroporation device. And it's not at all clear why it's given as electroporation versus an injection. Then you get a sub-Q with an anti-CTLA-4 monoclonal. So they're really clobbering this. They're trying to elicit immune response. And then they're using checkpoint inhibitors with either CTLA-4 or PD-1. And then patients with metastatic castration-resistant prostate cancer were on ADT. And then B-cell patients with biochemical relapse did not get ADT. And then their inclusion criteria were 18 years old. Patients with relapse required local therapy for diagnosis, rising PSA doubling time less than 10 months. And remember, they didn't get ADT, so they had testosterone and no metastatic disease. And then they had another population with metastatic disease where you needed to progress on AR targeted therapy, and then had some, and then different cohorts of CRPC. Next slide, please. And then, oops, back one. Right, so this is their dose escalation, and they moved up, n equal 3 on 1, 2, 4, 6, 3, and then finally they got in the metastatic castration prostate cancer group, they got cohort 7A, which got this adenovirus, cDNA, 80 milligrams of TRM plus PF, 300 milligrams of the PF, and then in 3B, it's the same thing. For metastatic castration-resistant prostate cancer. For B-cell, for biochemical relapse, they called it cohort 5B, which got essentially less of the checkpoint inhibitors. Cohort 5B got just 130 milligrams of the checkpoint inhibitor, and then cohort 1B didn't get any checkpoint inhibitor. or they got TRM rather, just the one. Next, please. So what this is a plot of the interferon gamma secretion. And what that interferon gamma secretion means that the T cell is responding to the antigen. And then in green are the T cells that responded to PSMA antigen. In blue are the light blue PSCA and dark blue PSA. So what these plots show, both in biochemical relapse and in metastatic castration-resistant prostate cancer, that they're getting a really pretty good immune response if you would measure it by the amount of interferon gamma that's in the serum. And notice they have a break point here, so that you have to be careful that some people had very low responses, but both of their graphs have a break point between 400 and 1,000, showing that some had really whopper responses in terms of producing gamma interferon in response to the antigen. Next slide, please. And then here's their Kaplan-Meier plot in both cohorts 3 and 8, and it's 50% is at somewhere near 10 or 11 months, which I think is pretty. In their modified intent to treat analysis, so getting 50% here is about 9.5 months. And I think for a first shot of people who are getting heavily treated, this vaccine approach has some promise. Next slide, please. And their conclusions: it had a manageable safety profile. It appears to stimulate antigen-specific immunity. And then some patients experience prompt and durable PSA 50 responses. And this is the key, without the use of ADT, which means it really was immune-mediated. And then the median radiographic progression-free of 9.2 months suggests promising disease control with this regimen of this triple antigen regimen. So again, I'm optimistic that we will see different methods of giving the antigen and different methods of and different responses. And I think that's the last I have.
Yep.
Okay, so thank you, everybody. This ran a little longer than we thought, so we're not giving you a hell of a lot of a break. We're not giving me a hell of a lot of a break. And then and I'm going to try. I'm looking at the chat window. I think gamma interferon, yes, is used for Hep C patients, Ted. But now I think, given that we have, if there's any burning question, you can just unmute and ask.
Jay, can you remove my screen sharing?
I don't think I can do that, or Len. I think only you can do that.
Oh, okay.
I'm not sure how to do it. If there's a way, I don't know how to do it.
Okay. Now, here we go. I got it.
Okay.
So if there's any burning questions, Len and I are certainly.
I had a question. For the very first drug that Len discussed, the one that had six previous treatments, did I misunderstand? Did that help people resensitize to abiraterone and Xtandi, or was that just a side effect, or was that even an effect at all?
I don't think they looked at that. Len, do you remember? I don't remember seeing that.
I'm getting muffled.
Yeah, please.
I got it. Nelson,
Mics, if you're not
unmuted,
talking.
mute yourself, please. Go ahead.
So what was the question, Jake? I'm sorry.
On the very first drug you mentioned, I don't remember the name, the one that had 6 previous treatments.
The etrumadenant.
Yeah. You mentioned something in there about sensitizing or resensitizing to abiraterone, Xtandi, et cetera. Is that one of the benefits of that treatment, or is that just was that just an aside that you mentioned?
I believe you're confusing two presentations.
I
I
probably
think
am.
I think you're referring to the new androgen receptor antagonist that was effective in a certain percentage of patients, even if they failed enzalutamide, apalutamide, ABI, all of them.
Okay.
Is that the one you meant?
I don't know, Len, to be honest. A lot of this was over my head. I'll have to go back and review again.
Okay,
Sorry.
no problem.
So first of all, I want to thank you guys for a huge amount of work, and
Amen.
I think that we sort of got the gist of what was a little important, but we maybe some of the details flew over us, but I think we got the gist. And I would encourage everybody who would like to look at the recording, which will get posted. And then I'm sure that Len and Herb would be happy to respond to any specific questions that arise from the from you reviewing the slides. I'm not
Absolutely.
great.
If anybody who wants a more specific or more careful explanation of anything that captured your fancy, please just email me and we can talk. We have no trouble. I'll be happy to go through it with you.
Okay, so I'm going to put Herb's, I think most of you know it, it's herb@ancan.org, but we'll put it in there, and it's len@ancan.org. So we'll go from there. We are going to go straight through, although, Herb, do you need to take a 5-minute break? Because we can handle
I'm
that.
good. Right now, I'm good. So
You sure?
yeah.
Okay.
All right. Actually, I'll disappear for a minute. I'm
Yeah,
going to mute myself.
That's a good idea. You disappear for a minute, and we'll keep them here until you get back. Okay. So it just worked out on this that Herb happened to be moderating today, and we couldn't do this next week because the rooms are in use, I think, every night. So so Len and Herb were kind enough to agree to do it today. I'll probably mention this again, but we do have a couple of webinars next week. One of them should be pretty interesting for any gents of color on the in the group. We've got a debate next week about prostate cancer treatment for men of color, and a guy, a urologist who's actually had a radical prostatectomy, and somebody else who was another doc who was not. And then the other night, if any of you have or know anybody who does have a rare disease, we've got a how-to webinar on advocacy. So we do have some of our folks here who also attend other sessions, be of interest to them. So those are the two next week. We are going to try and run a normal session today, and but there will only be one recording because we've just had to go straight through. So Jake has kindly agreed, because we thought this might happen, to give us some time pointers, so that if you don't want to listen to the first half, you'll know about where the group starts, the group meeting part starts. And with that, I'm going to turn it back to Herb. Herb, are we ready to go now? You're muted, by the way.
While we're waiting for Herb, we have someone to just join us on the telephone. Would you like to identify yourself?
Yeah, this is David Starr in Las Vegas.
Hi, David. Welcome to the call.
Hello, David.
Thank you.
Okay, I'm about ready here. I'm trying to catch up on Russ.
Yeah.
Gentlemen, please mute yourselves. If you're not speaking, please mute yourselves so we don't have any echo.
I think that was coming from David Starr. So David, we'll mute you for the time being, and then we'll unmute you when we get to you.
Okay,
Thank
okay. Okay, I'll start by welcoming everybody once again to the ANCAN Advanced Prostate Cancer Group. I'm Herb Geller, for those of you who weren't with us the last hour, and I'm moderating tonight. And I noticed we have several new people here that we can go through. But I think before I would like to just go through the roll quickly. We have a whole bunch of people, but I will try to go through the roll and see who would like some time tonight before we talk to the new people. So Alan Moskowitz, would you like time tonight?
No time tonight. Thank you, Herb.
Carl, would you like time tonight?
No, thank you.
Okay. Dave Starr, would you like time tonight? Dave?
Yes?
You would like some time tonight?
No, I do not. Thank you.
Oh, okay. David Muslin, would you like some time tonight? David? We don't hear you. I'll get back to you. Dennis Correa, would you like some time tonight?
No, thank you.
Dennis McGuire. Would you like some?
Not tonight, thanks, Herb.
Oh boy, nobody wants to talk tonight. Don Price, would you like to talk? Do you need some time tonight?
I don't. Thanks, Herb.
Oh, well, this will be very short. Gary, how are you doing?
Hi,
Would you like some
Herb.
time tonight?
Hi, Herb. No, thanks.
George, would you like to give us an update? George, are you there?
Muted.
George,
No, thank you, Herb.
okay. And Howard Hertz, are you new to this group?
Well, I was in another group. I guess it was the intermediate group, but I'm here because I just listened to the report from ASCO. But I'm going to listen in, but there's nothing I was going to say. So thank you.
Okay. Jake, would you like to give us an update tonight?
No, I'm good. Thank you, Herb.
Oh, boy. Jim Barnes?
We do have a
would you
couple
like
of
to
new
give us-
names, though. So I think we do have a couple of new people.
I do know, yes, we will get to them, but I thought I'd go through the list first quickly just because I have it, and we'll get there. And it looks like we're going to have time. Jim Barnes, would you like time tonight?
No, thank you, Herb.
Oh, boy. Jeff Markey, would you like time tonight?
No, thank you, Herb.
Okay. Jimmy, how about you?
Well, given the circumstances, I would like about 90 minutes, please.
90 minutes. You'll get 90 minutes.
Not 90. I want 90.
You got it, Jim.
No, you're going to have 90 because I'd rather let you do it. Maybe you can just play for us and I won't have to do this.
Hey, Jimmy, pull out your ukulele, Jimmy.
Yeah.
Listen for 90
I
minutes.
need money first. Money first.
Okay.
Joe,
Talk to
you, would you like some time tonight?
No, thanks.
Boy, Joel Blanchett. Joel, would you like some time?
I thought you were talking to me for the last guy, so I must have walked on somebody. And no, I don't need any time tonight. Thank you, Herb.
Okay. John McPhee, would you like some time tonight?
No, thank you.
Okay, John Ivory? John, are you there? I can't see you. All right, we'll go back to John. Julian Morales, would you like some time tonight?
No, thank you, Herb.
Ken, how about you? Ken Anderson. You're muted. All right, I'll come back. Oh, you're unmuted.
No, Herb, you're doing great. I'll be happy to give an update.
Good. We'll be happy to listen. Len, do you have anything you want to add?
I've got nothing, Herb. Thank you.
Les, how are things going with you?
Okay, nothing new for tonight. Thanks.
Mark Perloe, welcome back after absence. Do you have anything like your share with us tonight?
Nope, all is well.
Good. This is good to know. So I think we do have two new people, Marty Weiss and Marty Rotter, who I will get back to after we get through calling the roll, because I think they do want to add something. Nelson Pacheco?
Yes, I would like to do a short update.
Okay. Pat Martin?
I'm good.
Pat? Okay. Peter, how about you out in Hawaii?
Actually, I'm in Minneapolis. Yeah, I have a deep probing question.
Okay. We will wait for we will do your question. Peter Monaco.
No, nothing for me. Thanks, Herb.
Okay. And Philip Snyder. Are you new to us?
There you go. I didn't know you guys even existed until an hour and a half ago. So, to peek in, see what you guys are doing. And it's good to see that the group is absolutely the standing group. So that's good.
I'm having trouble hearing you.
I think we all are, Philip. You're coming.
Gentlemen, please mute yourselves if you're not speaking. Dan Friedman in particular, we're getting a lot of feedback from you. Thank you.
Philip Snyder, your mic isn't working. What you may want to do is just call in, and that might work a little better. But right now you're totally distorted. Sorry about that.
Okay. Russ Hoover, would you like some time tonight?
Yeah, I just have one quick question. If we get to it, if not, no
Oh,
big
we'll
deal.
get to it. Stan Friedman, would you
Okay,
like some time tonight?
Hold on, that was Rusty. That wasn't Russ Hoover.
That was Rusty. Oh, it was Rusty.
That was Rusty who said yes. So you got to.
Okay.
You've got Russ Hoover, and you also have Robert Snyder, who's different from Philip Snyder.
Okay.
None for me, Herb. Thanks.
And who was that?
That's
That
Stan.
was Stan Friedman.
Okay, Stan, nothing for you. And Russell Hoover?
Nothing for me tonight, thank you.
Okay. And Robert Snyder, are you new to us?
I don't think so, but I think he may be from the other group. But Robert, did you have?
I've never been here before.
Oh, have you been?
Can you hear me?
One of the other groups, Robert?
Yeah. I think with us two, talked with them, but
okay, but you're new to us.
I've got. I can give you a little report on what's going on with me.
Okay. We will. Sylvester, would you have any updates for us tonight?
No, thank you.
And Ted Healy?
I have to leave early today, but thank you, Herb. I'll pass to the next one.
And Tom Swartzel. Tom, do you have an update for us tonight?
No, I don't. Thanks, Herb.
Okay. Well, we have several new people, and I think we want to go through.
Herb, hold on a second. You missed Frank Favish.
Okay, all right. I'm sorry, Frank.
Nothing new tonight.
And why don't we just check, other than the men who are here for the very first time, did we get any? I don't think.
Did I miss anyone?
I don't think we missed Lee, and I don't think we asked Ben Nathanson.
Okay, all right. Lee, do you have anything to add? Would you like to share with us tonight?
Yes, I would. Thank you.
Okay, and Ben, what about you?
Nope,
tonight?
keeping it on the down low. Nothing tonight.
Okay, is there anybody that I missed?
I think Mark Perloe and Wang and Gao Shan just joined. Did you check with that?
Mark's been here, but if Gao Shang just joined, then Gao Shang, do you have an update for us tonight?
Your mic isn't on, Gao Shan.
You're muted.
You're muted. So we'll watch out for you and
I'll
come
get
back.
back to you. Yes. And David Muslin, does your mic work now?
He's looking very pensive there. Can you hear us, David? Give us a thumbs up.
A thumbs up, or you're good. Okay, no good. The mic isn't working, David. So did you call in?
Yeah.
Oh, there you go.
There
now
you
we can hear you.
Okay. No, I'm great, guys. Thank you. I'm good for tonight. Thank you.
Okay.
So why don't we start with our new people, and we have several, and we may not, we may have time, given the number of people, we may or may not have time. So the first three that we came to are Marty Weiss and Marty Rada. You're here to talk about somebody else, right?
No. I can talk about myself, but I'm not sure the protocol, how much you just. I'm here to talk about myself.
Okay.
Fine. Hold on a minute. We're talking to Marty Rada first of all, and then Marty. We got two. So Marty Rada, I believe, is here to talk about a BRCA situation for a friend of his that he cannot get to join the call just yet. Is that right, Marty?
Right. That's correct.
Okay. And Marty Weiss is here to talk about himself.
Right. So I know that. Right. Okay. So Marty Weiss, can we start with you?
Okay, this is the first time. Did we just discuss our clinical situation and issues?
So here's the way we'll deal with this. I'm going to ask you a bunch of questions, which sort of allows us to sort of place where you are and how we might be of best help to you first, and then we can go on and have a discussion. So tell us first, how old are you?
I'm 71.
Mm-hmm. And where do you live?
St. Louis.
Okay. And when were you first diagnosed?
1998.
1998. Okay, so tell us what they found. So in 1998, what do you remember? What your Gleason score was? And
it was 4+3. It was 4+3.
Okay.
Both lungs had cancer. It was not definitely felt there was any spread. My PSA went from 12 to undetectable initially. About 3.5 years later, my PSA went up to 0.2, 0.3. Then I had 64 grays of irradiation. And around 2008, my PSA came back a second second time. And ultimately it went up to 144, and I had a positive right obturator lymph node of 3.6 by 2.9 centimeters. And I went on Lupron in 2014, and my PSA is still undetectable. My obturator lymph node no longer shows up on the CAT scan. I have not had any type of PET scans. I have a couple. Yeah. I have a couple questions. Yeah. I'm sorry.
So
Go ahead.
basically, your current PSA is undetectable,
Correct.
and you're still on Lupron since 2014,
Correct.
and that's the only drug you're on.
Yeah, that's one question. After the Titan study, should I go on a second drug? According to the literature, I probably should. Up to now, my oncologist didn't think it was necessary because of the cost, potential side effects.
So tell us about your oncologist. Who's actually treating you?
It's oncologist Bruce Roth.
And where does he practice?
He's in St. Louis. Yeah.
At the university or at
Washington University.
He's at Wash U.
Yeah.
Okay. So, and I mean, at any time, did anybody do any genetic testing on your tumor?
Actually, it's being done, not on the tumor, no. I have a germline test pending through the Southern University of Washington, and the color group just received my saliva sample today. But I don't have the results back yet.
So how did you hear about us?
I think I was going through the internet and came across a group, possibly through us too. And I've found some of your lectures extremely good, and I started listening to those.
Great. So, so what are the questions you have that we can help you with?
Well, I don't think you can decide for me. My question is, I'm trying to figure out, reading literature, should I go on a second drug, enzalutamide, duralutamide, whatever. That's my question, especially with the most recent Titan study showing that the side effects weren't that much worse being on a second drug. The biggest side effect is going to be my pocketbook.
Right. So, what's and your current testosterone is essentially zero or
undetectable.
Undetectable, and your PSA is undetectable.
Correct.
Does anybody have any opinion or suggestions?
The first thing I would say is after 7 years on ADT, if it were me, I'd be talking to my doctor about going on intermittent for a while, seeing if I can get something back, and seeing how I feel and watching carefully. Is this Dr. Frohr? Is he a genitourinary medical oncologist, meaning he specializes in prostate cancer, or is he a general medical oncologist?
No, he's a GU oncologist.
He is a GU. So I would definitely be talking to him. I mean, again, this very much depends on your own preference, but we've got guys who have done this on this call, and you can talk to them right now. But if you're interested, I think I'd be asking not about going on another drug, but maybe I can get a drug holiday for a while.
I agree with Rick here, Martin. I'd be talking to your oncologist about taking a drug holiday. There are risks just taking Lupron alone. Cardiovascular risk, osteoporosis or osteopenia, muscle atrophy. Why not give yourself a break? Build up some muscle, some endurance.
How's the rest of your health, Marty?
Well, otherwise in relatively good shape. I exercise every day.
Good.
I do strength exercises 3 times a week. I try to eat a Mediterranean diet.
How do you feel about a drug holiday?
I'm a little hesitant. I mean, if what I'm on is working, I hate to change what I'm doing. Again, the question of cardiovascular, I guess another question, you go on relugolix or not. I don't know if it's even been approved yet for my situation, and also be a major toxic financial situation. But if I had to, I'd go on it. But right now, the Luprons seems to be working.
First of all, you can go on a different antagonist. You don't have to go on relugolix. You could quite easily go on say Firmagon, Tigarelix, which is no different from relugolix, except in the way that it's administered and the speed in which you can get on and off of it. But the question is, could you get it approved? So far, we've got about 4 guys on this call who are on it, and they seem to be doing fine. But if your metabolic issues are good and you don't have cardiovascular complications, then there's no reason to switch. The bigger thing is maybe it makes sense just to get off the drugs for a while. Now, we've had guys on this call who have considered have been in the same situation, and then they've decided to take a holiday, and they agree with their doc how long they're going to be off. In other words, when their PSA gets to a certain level, they'll go back on again. And there are some benefits to that. One of the biggest benefits is it can extend the time until you become castrate resistant, because the one thing we know is that ultimately you will become castrate resistant. But how long can you push that out? Because the longer you can push it out, the better you are. Anyone on the call right now want to voice some thoughts on intermittent and taking a drug holiday? Len obviously has done it and successfully. Anyone else? Peter, maybe.
Yeah, well, one of the advantages now that you probably haven't taken part in is that the high-tech PSMA scans are available now. So if you watch your PSA and it just starts creeping up a little bit, several months, above non-detectable to, approaching 1.0, you can jump on a PSMA scan and see where the activity is, whether it's in another lymph node or someplace that's treatable. So if you go off of drugs, you have that backup. I've done that several times and it worked for me. If I was in your situation, I don't know if I'd go on a second-line drug. I'm on a second-line drug, but I've got a Gleason 9, and I've gone through all kinds of stuff. But if it was my choice, I'd just stick with the old standard if it's working. I mean, you've been going at this for 22 years. That's an amazing track record.
Right.
So
have you asked your oncologist about either, I mean, obviously you haven't brought up the subject of a drug holiday, but have you asked your oncologist whether he thought you needed a second-line drug?
Yeah, he didn't think I needed to the last time I talked to him because I was doing so well on the Lupron alone, and he didn't want to add any potential or side effects or higher cost. We did talk about intermittent therapy early on. His feeling was, oh, the literature is not definitive. He thought people did a little bit better on continuous treatment versus intermittent. And he planned on keeping on ADT the rest of my life. To put it, adding other drugs as needed.
And are you having side effects of ADT that you find annoying?
They're tolerable. I can live with it, and obviously.
I mean, Marty, I think the consensus that we're hearing from your oncologist and the rest of this group is that, you know, it doesn't seem like a second drug is going to help you do anything. Now, the only issue I think maybe it's worth bringing up with your oncologist is the idea that maybe the literature's come a little further in the last few years about having a drug holiday. I mean, you've been on ADT for a long, long time, and you know that may be an indication for saying, let's see what happens if, and you may turn out you feel better. I mean, I don't know. I can't predict.
It'll probably taking several months to find out, because probably a long time before my endocrine system comes back to normal after being on it for so long.
Right.
But, you know, but that's okay because you can turn it back on. You can go back onto the drug pretty much any time, and you have some other alternatives. You know, you can. There are guys on this call doing monotherapy, second line drugs, and not doing the Lupron. Now, you know, you're concerned about your pocketbook, but to be honest. Today, for example, abiraterone is generic. So it's not that we just had somebody go on abiraterone. I think they're paying $50 a month. So it's not, it depends what drug you go on, but there are solutions if you want to switch it up. If you're happy where you are, stay where you are. But, you know, we're not docs. We can't give you medical advice, but we've seen a lot over the years. And one of the things we've seen with intermittent is that provided you watch it, you really don't lose anything. And it's so easy to watch today, especially with the new scans. And like you say, I mean, you could be, I think Dennis Correa's on this call, and he was on abiraterone and LHRH for 3 or 4 years, and he was off for 7 or 8 months, and then he started to see a rise in his PSA. Now he's going to respond to that when he feels he needs to. But, you know, one of the reasons I like it is because I think it keeps the cancer cells off kilter a little bit. They don't get so used to working around the situation. And that's really what we got to do.
Yeah, one other reason that I chose to do the intermittent, in addition to feeling better without, you know, having all the side effects of both the Lupron and the abiraterone and prednisone, is there's been literature and showing that the long-term use of Lupron, or ADT, can cause the cancer cells to morph into a neuroendocrine form of cancer, and which is extremely difficult to treat. So my philosophy is kind of get as long as I can on the drugs that work for me, but not to the point where I'm going to be on it continuously forever. There's a risk there. And so that's why I'm taking intermittent. Right now, my PSA is starting to rise. As of this week, it's back up to 2.8. And I'm scheduled to get my PSMA scan July 1st to see what my next step should be.
Yeah. So Marty, I think, I think you can hear the consensus of this group, and probably the next thing is go talk to your oncologist. Certainly, I don't think he's going to want to prescribe another drug, but I think it's worth having a discussion with him about, does a drug holiday, which and is what Dennis said, basically keeping the cells under continual pressure does promote the opportunity for mutations. If you take away the pressure, you may find that the cells don't have the mutations and then continue to respond if you need it. But I think you need to have that discussion with your oncologist.
Martin,
So do you have any?
Martin, how old are you?
71.
It's possible that after 7 consecutive years on Lupron, your testosterone, even if you stop, your testosterone may never recover. So, there's probably very low risk of your PSA rising if your testosterone level isn't rising. Or certainly if it does, if your T levels rise, it would probably be very slowly. It would take you quite a long time to get to a normal level, I suspect. But I mean, do you have any hot flashes or any? You do. Yeah. So you could be free of that. Do you have any muscle aches, joint pains, things like that?
No.
No. Well, that's good. So you do tolerate it well.
So, I mean, I think probably I think we're all of one mind here that at the very least you don't need another drug, and there's lots of possibilities to talk about actually going on drug holiday for you. And please, I think if you talk to your doc, come back and let us know what he says.
Okay. Yeah, I'll see him this fall.
Right. Okay. Thank you very much.
Thank you. Thank you for your time and opinion.
Okay. So before we move on, I just want to pick up a few new people and ask if they need time. Ben, do you need some time tonight?
No, thank you, Herb.
Okay. Eric, do you need some time tonight?
No, not tonight.
Okay. And Larry, I see you're there.
Yeah, hi, Herb. I'm good tonight, thanks.
Okay. Okay, so why don't we
Herb,
talk?
can I just say, Marty, if you're not on our reminder list and you'd like to be on our reminder list, just put your email in the chat window. That's the little bubble, or you can send it to me, or you can send it to me privately and rd@ancan.org, and we'll make sure you get a reminder before any meeting. That goes for any of you who are not receiving reminders and you want to and you don't think you're on our list. I think most of you are, but if you're not, just let us have your email. Thanks. And Herb, check with Joe Gallo.
Oh, is Joe here?
Yes, he is.
Okay, I missed you. Joe, would you like some time tonight?
That's. I was trying to answer at the same time that Joel did. No thanks.
Okay, and Jim Schrate, would you like some time tonight?
No, I'm good. I'm just here to listen. Thank you.
Okay. So I guess the next person we'll talk to is Martin Rotter, who wants to bring up a friend's case with a BRCA mutation. So Martin, are you there?
I'm here.
Okay, so would you please tell us a little bit about what the situation is?
Okay, my friend.
Could you speak up a little? Could you speak up or get closer to the mic?
Is this better?
Yes.
Yes.
Okay. First, I just want to thank this group. I participated 7 years ago when I went through a recurrence after a prostatectomy, and I found it most helpful, and I've quote unquote graduated, and I'm okay now. But I'm trying to
Good.
pay it forward to my friend. 77 years old. PSA was normal until this year, until November of 20. The original reading was 908 with bone marrow, that it had spread to the bone marrow. His PSA has been bouncing around. They gave him Casodex before they started him on Eligard, and it went from 208 to 837 just on the Casodex. Once he started the Eligard, over about five months, it went down to a low of to lows of 9 and 10 until June 11th of this year, and it went to 238. They had done a germline and discovered he had BRCA2. He's had 3 rounds of Dosatexel, and that's basically it. He's seeing a regular medical oncologist, and that person's also a hematologist. Apparently that's helped with his bone marrow, because while his values aren't normal, they're close to it. He's been diagnosed also with anemia and thrombocytopenia.
Right. Well, that's very common with either both Lupron and Dosatexel. So you say he had 3 rounds of docs. Is there
Correct.
a reason they stopped after 3?
I assume it was only because that his PSA had gone down so low, but no, I don't. They didn't add any other drugs to
Because the normal guidelines would call, if you could take it, 6 rounds of Dosatexel.
Yeah, I wondered about that too. I do not know. One of the weird things is, and I don't know if this is relevant or not, it's not clear. He got 1 3-month shot of the Eligard back in March, and it's not clear whether or not he ever had a second one, which would have been, he got his first shot in December, I'm sorry, and he never got another shot, which would have been due in middle of March. So I don't know if that's playing a role, although during that time, his PSA was very low, relatively speaking.
Well, I mean, there are a couple of questions that obviously come to mind. If he hasn't had a Lupron shot, then this is a major issue, right? Because it was received, according to the way you tell us, it went down with Lupron. Now,
correct.
The other part of it is the guidelines that we've talked about here, and you've heard, if you participated in our first session, would suggest that maybe that you really need at least 6 rounds of Dosatexel, and then if that's not working, then you need something like abiraterone in place. Now, yes, he had, and then this is where Rick and I may differ. That it seems to me if he hasn't had Lupron, then he needs to see if this is still hormone sensitive. We don't know that it's not. That's a question.
His latest testosterone is 11.
Well, yeah, that's pretty low.
So, I mean, it's possible that he got a 6-month shot of Lupron originally, Marty. And this is always a problem when we're trying to navigate somebody who isn't with us. But I think I want to get to the issue that you wrote to me about originally, which was his doc wants to give him abiraterone, and he thinks he should be getting a PARP inhibitor like olaparib Lynparza. Well, first of all, the approvals for both Lynparza and Rubraca, or in deference to Professor Geller, olaparib and rucaparib, are that you have to have had one of the second line anti-androgens before it's prescribed. Now, in the case of olaparib, you don't have to have had chemo, but in the case of rucaparib, you do have to have had chemo. That's really the difference in the approvals. We don't know if rucaparib's a better drug. I think if I'd done the chemo and I'd done some abiraterone or enzalutamide, I probably would select the rucaparib rather than the olaparib, but you know, it is a bit of a toss-up. Can you get a PARP inhibitor, which is the drug we use to treat people that have a BRCA mutation, before you've had Dosatexel, before you've done abiraterone or enzalutamide? It would be difficult. There are a few docs around the country, as I wrote to you, that might be able to do that for you. I mean, the only person I think of really is Dr. Schultz, because somehow or other he's a magician in getting around these FDA approvals. And if you had a local doc in Atlanta, like Dr. Mark's doc, who was willing to work with Schultz, maybe we could get him straight on to a PARP inhibitor. Yeah, I don't know that Herb and I have a big difference on it, and I want to give Herb the chance to respond too. But we do know that the PARP inhibitor is going to hone in right on that BRCA mutation, whether or not you're still sensitive to your hormone drugs. So, and I don't know where the testing stands. I did try to look it up, but there isn't an awful lot of testing being done for BRCA in a hormone sensitive situation. I think there was one trial I pointed you towards. Oh, Mark says to me, he doesn't have a local MO in Atlanta. So we'd have to find, but you know, what we could do is we could backdoor through Peter or through Peter Kafka or through Dr. Mark. We could backdoor to Schultz for him and see if Schultz has got somebody to work with locally in the Atlanta area. But I mean, those are my thoughts, and that's what I provided you with in writing. Herb, what are you thinking?
I mean, I don't know. I personally think that I'd like to go with the hormones first. It's the guidelines, and it will, if the cancer is hormone sensitive, it doesn't really matter what kind of a DNA repair mutation it has. It's going to respond, and you're going to get, and if you can get time out of that, my opinion would be go with it. But I'm not, you know, again, I don't know this case. I don't know. There could have been a reason he didn't complete Dosatexel, which means, and he's anemic. So there's some issues there that may be that you don't want to keep his hormones down, and you'd rather go with a PARP inhibitor. As we're not physicians, and I don't really have a complete understanding of his situation, it's really hard.
Herb, let me add this, because this is something that Marty wrote to me. He said that that he did have abnormal red blood count and hemoglobin level, and so
right,
that
he said he was anemic.
Right. So that might have been, you know, the other thing, by the way, is that he might be sensitive to a platinum-based chemotherapy regimen.
That's where I would go. That's exactly where I would go.
They did tell.
I did chemotherapy last year. I was anemic. I had to take, you know, injections to bring my red count up. But I went through 6 rounds of Dosatexel with carboplatin, with a somatic BRCA2 mutation, and I'm here to tell the tale a year later. So I think it's worth leaning on the doc and getting on carboplatin.
I mean, does he have a GU oncologist?
No, that was one of my questions. If anybody knew of any close to Atlanta, I understand that we don't have any here. But I did want to comment on the more chemo. He did say, the doctor mentioned that anything else was too strong and he couldn't tolerate it, although he seemed to have tolerated it well.
Okay.
Well, no, evidently there was a reason. He must have had severe anemia or thrombocytopenia that they felt, or other side effects that they couldn't continue with Dosatexel.
In terms of, is there anyone in Atlanta? I'll let Dr. Mark answer that. But there are a couple of GU medical oncologists at Emory, but I don't know how good. I mean, one of them is supposed to be good, but you know, we get sketchy reports. But I mean, you could, Mark, what are your thoughts about the GU med oncs at Emory? You probably check them out.
I just haven't found people who were willing to consider a situation like mine. You know, as you talk to me, we really don't know who I am and what my situation is, because the pathway was not according to what NCCN guidelines would suggest. So in those situations, rather than taking the patient and fitting him in the box, you have to maybe find a different box to address that patient. And I don't see a willingness to look at things that way. Where with Schultz, I found that we ran through all the possibilities, pluses and minus, and then I was part of making the decision.
Yeah.
I mean, I think.
Go ahead.
I mean, I certainly think almost any if any of our good GU oncologists should look at this case and then make a recommendation. I think we don't have enough information right now, and I don't think you don't have it either, Marty.
No, he doesn't either. That's another issue. The doctor's not really forthcoming, or he didn't react to when they had that giant recent jump into 237 from 10. So
I think he needs a new doc.
Well, that's what I was asking, if he may be willing to travel in the Southeast or maybe the Northeast. And that's why I was wondering if there's anybody at Mayo in Jacksonville or anywhere, Florida or anywhere around there.
Well, I mean, yes, there are. I mean, we could refer him with the greatest of pleasure to Dr. Korn, C-O-R-N, Paul Korn at MD Anderson. We could refer him to Dan George at Duke. I'm trying to think. Those are the first two names. We could probably find somebody. We could find people in Baltimore.
Right. Certainly Hopkins, we could find somebody.
You know, at Hopkins.
Okay, I can explore that with you. I did have one other specific question to go on the second line drug at this point. The doctor told him he couldn't go. He is diabetic. The doctor, and it's he does take meds. The doctor told him he could not go on Zytiga because of the prednisone.
Right.
And so is that accurate?
Yeah. Yeah, it's not a good idea. And because of the prednisone, it's not a great idea. So normally what they'll do with men who are in that situation is, rather than putting them on abiraterone, they'll put them on enzalutamide or apalutamide.
Right. He's recommended enzalutamide.
Right.
Would a scan be needed
Supposedly,
at this
the
point?
hydrocortisone is less likely to cause the sugar abnormalities. So I think that would be a question to discuss with the medical endocrinologist beforehand. This is a fairly low dose of steroid, and if someone is well controlled as a diabetic, We used to use this with the fertility patients, and we really didn't see any kind of change in the insulin requirements.
You know, I don't disagree with you, Mark, but it's a tough one because even the GU medoncs, and we just ran across this recently, they just don't like putting men with diabetes on prednisone. But there's no reason why you can't challenge them and ask them about other types of steroids that could stimulate the adrenals that might be less damaging than, but you know, that's above my pay grade. So I'll defer to Dr.
Yeah.
I mean, my sense here is, Marty, we can't, with the information we have, we can't go much further.
No, but you've been helpful to get me to think of some things to get him to ask about. So I appreciate that.
And he's welcome to join. If you can convince him to join us in person, that would be great.
Yeah.
And Marty, there are a couple of GU medoncs at Emory. I just don't know how, you know, we've never had much luck with them, but I'm trying to find their names right now, and I can't remember their names. If I saw the name, I'd remember quickly, but I'll look for it afterwards and I'll send it to you.
Okay.
All right. So please keep us in the loop, and you know, if you want to send us email offline, that's fine too, if we can be helpful.
Okay, be glad to do that. Thank you.
Okay. So before we go on, there are 3 new people who joined us late, and I just want to touch base with you. David Starr.
No, David Starr said no, and you already asked him.
I did. All right.
Yes.
I missed that. All right. Wang Gao, do you need any time tonight?
Gao Shan. You there, Gao Shan? You're muted right now. Gao Shan, there you go.
Yep, I was across the room, sorry.
Do you need any time tonight?
I don't have anything to really go through, except I finished my 32 sessions of radiation. Didn't really have any issues or side effects. And on the 16th, after the radiation ended, I had a PSA test, but I have yet to get the results. I need to follow up on that. Other than that, I had my 3rd Eligard shot, and the next one is scheduled for end of August or the 1st of September.
Okay, well, come on back and you can give us.
Right. And Kang, do you have any? Kang, would you like any time tonight?
Oh yes, if there is time, I'll just give a quick report about the visit of the oncologist.
Okay. And can I just add for Marty? Now I remember who it is. It's the GU medonc is a guy called Bradley Carthon, Carthon. You've probably heard his name before from your group. So he is a GU medonc. Some guys like him, other guys find him a little arrogant. But that's if you don't want to go out of Atlanta, that's probably the guy that you got to see.
Okay, so we'll go on to Robert Snyder. Hi, how are you? You're unmuted, but we can't hear you.
Pretty good. Do you want to ask questions first? Yourself better?
It's better. It's still garbled.
It says it's. Oh. Okay. Can you hear me now?
Yes.
Yes, that's better. So, this is your first time with us?
That's better?
Yes. Yes. We can hear you.
Yes.
So is this your first time with us tonight?
Yes.
Okay. So I guess you've heard us.
It's my first time.
Okay, so I'm going to ask a bunch of questions that are going to help us orient ourselves. So how old are you?
Okay. 74,
And where do you live?
Rochester, New York.
Okay. And tell us when you were first diagnosed.
In September of 2015.
Okay, so that's 6 years ago. And what was your Gleason score at that time?
I think, I'm not sure, 9.
9. So
My
that's
my PSA was 28.
Okay. And what did they do at that time? What was next?
Well, I got scanned, so then they found out I had a spot on my femur and my pelvis.
Okay.
And then I started on biclutamide and the Lupron, and then the PSA went down to 0, and my testosterone was down to 0.
Okay. And then that was
then
in
they gave
20.
me radiation on my femur and my pelvis.
Okay, so they did spot radiation.
Yep.
Okay, and then so that was in 2015, and where was that was done at U of R or?
Yeah, it's strong U of R. Yep.
Okay.
27.
Then I got resistant to the biclutamide, and in 2000, around the end of 2016, I started on Zytiga. That worked good. That worked good for a couple years, and then I got resistant to that, and then let's see, I ended up getting some sciatica real bad, and I got scanned again, and they found an egg-sized tumor near my spine between my pelvis and my prostate. So then I got radiation again on the tumor in my prostate. But then in let's see, February of 2020, I had Dosatexel. Well, this was a trial. It was you could either get Dosatexel by itself or Dosatexel with radium. I ended up getting just the Dosatexel by itself, but I had a real bad reaction to it, and my legs all swelled up, and I got a real bad rash over both my legs and on my back, and it was pretty bad. I ended up in the hospital for 9 days, and they cut that right out. But I had a lot of bone pain after that, and
so what's
went
your
on
current
Oxycontin
PSA?
for a while.
So what is your current
My
PSA?
current well, I went on the other thing I did is I went on Provenge for a while, went through 3 treatments of that, and then I started on Cabazitaxel because the Dosatexel didn't work for me.
Right.
I had 4 treatments of that. My PSA was back up to, it was at 42 for a while, and the Cabazitaxel brought it all the way down to 7. And then it started going back up again. Even when I was on the Cabazitaxel, I went back up to 11, and they decided they think they're going to put me on apalutamide, but I can't believe how expensive that stuff is. They said if you had to pay for that yourself, it's about $20,000 for 1 month. And
so
my insurance though will bring it down to $3,000, but they suggested I go on what's it called? There's another
enzalutamide,
Epic. They said you could go on Epic, and that would, along with my MVP insurance, and that would help bring the cost down some more. But I got to fill out a form for Epic so I can get on that.
So who is your oncologist at Rochester?
Dr. Victor, a woman, Dr. Victor.
Okay. And is she a prostate oncologist, a GU oncologist?
Yeah. Yep.
So we hear where you are. So, and what about, have you done any current scans?
Can I just ask a question
Yeah,
there?
I did get a scan, and they found some more spots. I got a spot on my T7 vertebrae, one on my rib, and another one just below my left knee.
Mhm.
But I'm
And did you
feeling
have
pretty
any,
good.
right, have you had any genetic testing?
No, yeah, I guess they did. They said I don't have the BRCA2 anyway.
But what, you don't have any or just BRCA2?
No BRCA2.
Okay, but has the tumor been tested for mutations?
No.
Okay.
How did they do the test? Did they get you, was it a spit test or was it a blood test? How did they figure that you didn't have BRCA?
Blood test, I believe. They swabbed my cheek and
Okay,
but
they
then
swabbed your cheek. Okay, that's
yeah.
all we need to know. So there's a couple of things. The first thing is you got to get this Dr. Vic, are you sure Dr. Victor specializes in prostate and bladder and kidney, or is she more of a general oncologist?
Well,
Or do you not know?
I'm not. Yeah, I guess I don't know for sure.
Okay, so the first thing you've got to do is ask her, do you specialize in, it's called genitourinary, just say GU. Those are all of the diseases. You got to make sure you got a doctor who specializes in that. Now, there's a guy in at the University of Rochester who does, whose name is Veltheisen.
Oh.
Dr. Van Veltheisen.
How do you spell that?
Deldhuizen, Dr. Van Veltheisen. Okay? And he treats a number of guys, a couple of guys who is sometimes on this call, often on this call. And he seems to be very good. And that's the doctor. I don't know Dr. Victor. We'd have to check her out and see if she is a GU oncologist. But I can tell you that Veltheisen is.
Okay.
Okay.
All right.
And you need to you need to be sure that's what you're seeing. Secondly, you need to get your tumor analyzed, and you can do that with a blood test, and it's covered by Medicare.
Okay.
All right, because we've got to see if we can find something that will treat any mutations you might have. You may not have BRCA, but there are other mutations that have special drugs. And we've got to see, because right now the Dosatexel isn't working. It's not that it's not working, but we're not getting your PSA down as low as we would like, right? But I mean,
They keep telling me there's another new chemo that they're using in Germany that hasn't been approved over here yet. I don't know the name of it. I think it's a bunch.
I wonder if they're talking about lutetium.
Yeah, that's not a chemo. It's a radio. It's a treatment that takes something that's radioactive to the cancer cell, and it's very close to getting approved here. It's approved in Germany. It's approved in Australia, but it's not ready here. But it's close. It went into an accelerated approval last week. We've got 3 guys in this group who are doing that treatment in clinical trials.
Yeah, they're trying to get that for me, so that's why they wanted me to go on that apalutamide in the meantime to hopefully then they can get that here for me.
Okay, well, when they say they're trying to get it, are they asking for compassionate use, or are they saying, well, when it gets here, we'll give it to you?
Yeah, I think they're just saying right now when it gets here, they'll give it to me.
So you can push them to get you're a candidate for what's called compassionate use.
Okay.
And you can be talking to your doctor about compassionate use because they are providing this lutetium for compassionate use. We know somebody who just got it.
That's the same thing as the right to try?
Yes, essentially, yes, quite right.
Okay.
Okay. So,
Thank you for that.
Yeah, this is very familiar. I feel like I've spoken to you before, Mr. Snyder, because I remember this Dr. Victor. I've looked at Adrian Victor. I've looked her up before for somebody. And you know, I think I don't know if you can switch, but Van Veldhuizen would be a better option.
Switch before.
What's that?
They've told me I could switch before.
Okay.
Because I was asking them that because there's another place where I could get chemo closer to where I live than that is, and they said I'd have to switch to the oncologist over there, and that's part of the U of R. Maybe that's where that guy is you're talking about.
Well, I think it's more important. I mean, if it's part of U of R, you can usually get the chemo anywhere you want if it's part of the hospital, but the doctor that you want as your quarterback is Dr. Van Veldhuizen.
I'm having trouble, Rick, showing that he's on the U of R website anymore.
Oh, maybe not. Veldhuizen, you said.
Veldhuizen, Veldhuizen.
Okay.
All right. I mean, I think he still is because I think Tracy still sees him. But we can check with Tracy.
Okay.
But anyway, those are a couple of suggestions for you to consider compassionate use for this lutetium 177. And
I mean, can I ask another question? What's your current blood cell counts?
Well, they must be. They were okay to get the cabazitaxel, but I don't know. I don't know what the number. I don't know what the numbers are at, but I always get my blood tested before I get the cabazitaxel, and it's always been approved. And I just ended with that because it's going back up anyway.
how many did you have? How many did you have time?
I had 4 treatments.
Okay. Okay, now as far as apalutamide is concerned, first of all, are you a veteran?
No.
Okay. As far as apalutamide is concerned, Jensen has programs for it, or you can try enzalutamide, and you should be able to get that relatively cheaply too. There are definitely programs for enzalutamide.
Okay. Does that have more side effects than the apalutamide?
But about the same. There are almost no difference.
Okay. Once before, when I was off Zytiga, I went back on it again for a little while, and it worked for me. So I was asking them if I couldn't do that. Maybe.
You could. Because
have you heard other people going off of that for a while, and then it worked again?
Yes, after they've done chemotherapy.
Yeah.
But again, you need a specialized prostate cancer oncologist who's going to know that.
Okay. Well, they let me go. I was with Dr. Victor, and when I went back on the Zytiga, they let me go back on it, and they thought it might work again for me. But
okay, how did you come to us, Robert? How did you find us?
I think it was through us too.
Okay, well, and do we have your email so we can send you reminders before each meeting?
Yeah, I think. Well, I sent it to you, and I got a reminder for this one.
Okay, then you're in good shape.
Okay.
Right. Great. Well, we definitely want to be in the loop, and I think Dr. Victor is not a GU oncologist. I cannot find, but we better check with Tracy because I can't find Van Velthuizen on the Rochester website at the moment.
Okay.
So someone else may want to check that.
Oh, I was going to tell you too. I went on Radium for a while. Pardon me?
So Joe Murgy actually said Van Velthuizen is still there, and so I think he's the person to want to go to.
Okay.
He is the guy. Now stay away from the radium.
Oh.
He already had radium.
I already had radium.
Oh, I thought you said you didn't get it. I thought
Yeah,
you
I had. Well, this was after I went through that trial. Later on, I had a lot when I had the Dosatexel. Right after that, I had a lot of bone pain because when they took me off of that, and then I went through the radium treatments, and let's see.
Okay. So
well, let me.
If you did the radium
treatment, it was before I went on the Dosatexel.
Okay. Robert, hold on. If you did the radium treatments, you're not going to be able to get into a trial. So the only way you can get lutetium right now is through compassionate use. Even if you were, because you would be excluded from any trial because you've already done the radium. Okay.
Okay.
Now that doesn't mean to say that you won't do well with the lutetium. It's just the way the trials are set up. So you got to talk to them about getting Van Velthuizen or one of these docs to apply for lutetium 177, applying to AAA, which is part of Novartis, Advanced Accelerator Applications. They have a whole procedure and you can apply to them for compassionate use. And since you've tried everything else, you may be a good candidate.
Okay. I liked the radium though when I did use it because I had a lot of bone pain and it took it all away.
Right.
Well, right. Great. So I think that definitely GU-onc, and I think lutetium would be something you really want to push. In the meantime, I think having apalutamide or darolutamide might work for a while.
Okay.
If you haven't had it before.
Yeah, I haven't had it before. Thank you.
Any other questions for us? So just keep us in the loop. And if you
have you ever anybody added Epic to their insurance to help bring down the cost on some of the drugs?
I'm not sure.
I don't know. I'm even familiar with Epic. Does anybody know what Epic is?
Yeah, it's a New York State add-on Part D plan. But there's a pretty good sized deductible, but I think my deductible is like $1,300. So it doesn't do anything until you hit that.
Okay.
Joe, if your deductible is $1,300, but do you know if it works for some of these fancy drugs, the very expensive drugs?
I do not know. There's very little information on the website.
Okay.
So, but supposedly it pays for some drugs that Medicare does not pay for.
Okay.
But
Well,
that's just
the pharmacy at U of R, they were the ones that suggested I do this, so they must know that it'll help pay for some of it.
Okay, well, I think you've got to do a little more digging directly with Epic. You can probably find out what drugs they cover and what drugs they don't.
Okay.
Yeah.
Thank you, Joe. Joe, where
Right.
are you? Aren't you? You're somewhere up there, aren't you? Where are you?
I'm right near Syracuse.
Right.
So I pipe in here a little bit on this subject. If you can get a doctor to recommend darolutamide, that's what I did, and I went on a 2-month trial, and after that, Bayer covers me directly with their patient assistance program. Mine doesn't even go through insurance. They send me the drug every month.
For enzalutamide?
No, darolutamide.
Darolutamide.
Bayer.
So
Okay.
the problem is this, Robert, and we have to move on. But the problem is
Right.
this: you're not. Darolutamide has the best side effect profile, less than enzalutamide, less than apalutamide. You are not strictly approved for darolutamide, unfortunately.
Okay.
So the doctors have to do some gymnastics in order to get it for you. And Peter's doctor was able to do that. But if you could get darolutamide, it would be great.
That starts with a D?
DAROLUTAMIDE, darolutamide.
Okay.
Okay, and that would be the best. That's made by Bayer. The other two drugs, enzalutamide and apalutamide, are made by Pfizer and Janssen. Okay, Xtandi and Erleada are the trade names. So it's going to be hard. So Peter's right, but maybe somebody like Van Veldhuizen can figure out how to get it for you.
Okay.
We don't know, but I think the biggest takeaway from this is get them to push Novartis AAA for compassionate use of lutetium.
Okay.
Okay, I think we have to move on.
Yeah.
Thank you.
Okay, Ken Anderson, you had an update. Ken, are you with us? Okay. Hopefully his mic is on. He might have just walked away. So I'll come back. Jimmy, tell us what's up in 90 minutes.
Only got 90. I don't think I get 90 anymore. I'm gonna cut it back down to 65. Good to see everyone. I don't have much. I mean, compared to many of us, I'm just continuing to have a good time here with most of everything, except one thing is just sort of put out a question. I'm doing fine. I have my testosterone is now at about 500. I do feel the difference. I tolerated it well, but I feel now in retrospect that I did, but I know that I feel differently. I have a lot more energy and mood's elevated, but I'm not too attached to it. I'm really glad. I'm just trying to really watch my food and get rid of this fat that I gained on it. And Herb, as you know, that's not easy to do. Many of you know that's
it
not
ain't
easy.
It's just not easy.
I have really cut back my food a lot. I'm very, very careful, and I'm doing a lot of high intensity workouts, and it's still tough, but that's not what I want to talk about. Everything's fine. From way back when I just thought I had maybe some BPH back, when I should have been checking this out, 2013, 14, I started to have a nocturnal frequency, getting up a lot at night to pee. And I didn't have any other symptoms of what they called, prostate cancer symptoms. I wasn't getting checkups or anything. It was stupid, but I didn't have a weak stream. I didn't have feeling of not completely emptying and some of the things I talked about, but I did get up at night kind of a lot. And being really athletic and drinking a lot of water and also being a kind of a coffee hound, I figured that I was just really, just I had a lot of fluids going through me. And when my wife suggested that I, maybe try to cut way back in the fluids and see if it still was like that, I did. It still was like that. And that's what led me to getting diagnosis in the first place. After all this and the prostatectomy and the treatment, now the artificial sphincter, everything is good, except I still get up basically every, I keep track, like the first 2 times I get up at night or every hour to 90 minutes. And then after a couple of those, I'm able to sleep 2 hours at a time for the remainder of the night. But basically, since this has all started, I have to stay in bed a long time just to get a decent night of sleep. I've tried imipramine and oxybutynin, which are, as you may know, they're drugs that are supposed to relax the bladder. I know there's a host of different medications, but what we do here is we talk to doctors, and then doctors tell us what they tell us, and then we come here and we share experience, and maybe somebody has had enough nocturnal frequency of urination. And I go when I get up. I don't get up and go a little bit. I go. So I try to cut back my fluids, and it still seems like I have a pretty, healthy pee about every couple hours at the most when I'm sleeping. And I'm just sort of kind of, scratching around for answers. And I've asked my urologist, I've asked my, the rest of my team, other than the imipramine and the oxybutynin, which also causes some constipation in me, although I can deal with it if it really worked. It doesn't seem to do that much good for me. So I'm just curious if anybody else has been able to make any inroads on this issue, if they've, I hope you never did, but have had this issue of having to get up.
I mean, Jimmy,
pretty frequently.
I'm up. I'm like you, man. I'm up at, and then at the beginning, it's maybe an hour and a half, and then 2 hours, and then maybe 3 hours at the end.
Now, why did you have to say that? Why did you have to say that? That means it's normal, and I have no complaint. Okay.
I mean, it's just, I don't know what to do about it. The only thing is I'm in a certain sense that I'm lucky. I just fall right back asleep.
So do I.
So,
God bless for that. Yeah, that's
so, I figure in a way it's a blessing. I get like 4 REM sleeps a night instead of 1. So my dreams are just amazing.
I never thought of it that way.
Jimmy, I want to suggest a drug for you, okay? Because some guys have had really good luck with it. It's called, the trade name is Myrbetriq, MYRBETRIQ.
Hold on. How am I supposed to remember that? Still got Lupron brain left over.
All right. We'll put it in the
chat window for me. Put it in the chat window for me. Tell me what it is.
Chat window.
But tell me about it.
The generic name is Mirabegron, and it is a much more nuanced version of drugs like tamsulosin. It works in a different way. I think Herb would be able to explain it. He would, but it relaxes your bladder in a different way. It was pretty expensive when it first came out. It first came out around 2014 or 15. It may have gone down in price since then, but guys who have tried it have had some good luck. Not everybody, but some have. I'm putting it in the chat window right now because it's hard to talk to you and type at the same time. Okay. Anybody use Myrbetriq or know anything about it?
I don't know anything.
Anybody try anything else that they like?
There's something natural that I've used that seems to help me. Some of the prostate helps. They have pumpkin seed oil in them. So I bought these 1,000 milligram pumpkin seed oil pills from Now Pills. You can get them online, and they tell you to take 2 in the morning and then two at night. And I just been taking 1 each time, and it helps me. Sometimes I was getting up every couple hours, like you said, but sometimes now I'll sleep for 5 hours straight at least or more with these pumpkin seed oil pills.
Wow, what is it called?
Herb wants to know you heard 5 hours, and Herb's ears went up.
Pumpkin seed
Pumpkin
oil.
seed oil.
Yes.
Yeah, 1,000 milligram pumpkin seed oil pills.
It turns your schmeckle orange.
And
I'll get me
some of
some syringes for that.
the ones that have saw palmetto in them, they also, some of them have this pumpkin seed oil in them. So that's why I started trying that, and it seemed to work for me.
Thank you.
You can buy pumpkin seed oil at the health food store too, in liquid form. It comes from Austria usually.
You can get it on Amazon. I just looked on Amazon.
Yeah. So this subject came up. This subject
And that's a lot cheaper than a lot of those other drugs.
Yeah. Peter, go ahead.
This subject came up once at a PCRI conference several years ago, because I mean it's a common thing. I have it too. I'm up at least every 2 hours, maybe an hour and a half. And the way it was described to me, I think it was I don't know, one of the docs at the PCRI conference went into it, and he said essentially our bladders have a certain amount of elasticity to it. They're like a balloon originally, but because of what we've all gone through, the hell we've gone through in terms of treatments and this and that and the other thing over the years with our cancer, it loses the elasticity. So it's got kind of ridges in it and stuff. So it isn't so much that our bladders can't contain the urine, it's that they don't expand like a balloon. So they don't have the increased capacity. So it just, it reaches a point where we just got to get up. And I mean, that's not a great thing to sound like you got to live with it, but I've been living with this for a number of years, and I just do it. As Herb said, you just get up and then you go back to bed and hope you don't wake your partner up. But,
yeah, don't get me wrong. I can live with it, of course. Yeah. But I naturally, I look back to my youth, and boy, I used to stay up all night drinking tequila, sleep for 10 hours straight, and get up and get that fire hose out and go for about 2 minutes straight. And that's a long time ago.
Yeah,
but I can still drink the tequila, Jimmy. That hasn't stopped.
That's good. That's good. Okay, move on. I'm done.
I've got a bottle of tequila you can come over and share anytime. So Peter, you said you had an update for us.
No, I don't have an update. I have something. We considered this several months ago, and it's come up to me again more recently. I think I had an answer to it a couple of months ago, but it's fallen flat. A number of the drugs that some of us take are drugs that you take several times a day. Like I take darolutamide, I take it in the morning, and I take it in the late afternoon or evening. Zytiga is like that. You have to take it twice a day. And there's several other drugs like that. And with brain fog, I find myself spacing out the afternoon doses and evening doses a fair amount of times. And I've gone to things like I take the bottle and I turn it upside down. So if I'm sitting at my desk, I'll look over and I'll notice that, hey, it's upside down. It means I still got to take it this afternoon. But it doesn't always work. I get involved, I'm active, I get involved with other things, and I'll space it out and I'll go to bed and I'll forget my afternoon or evening dose. Does anybody have any tricks that they've invented to not space out the afternoon dosages?
I think one trick would, if I were that way, I'd program Alexa to just say, take your dose.
Huh.
Peter, another remedy that I've used for someone in my family is to have like a 7-day pill dispenser or a pill storage for a week, where for each day you're supposed to put in the different pills that you take on that day. So you would know in the afternoon if there were still 2 pills left that you had not taken the afternoon dose.
Yeah, I use these things, but I usually just fill them up for the morning. You know, I take everything in the morning.
Right.
I never thought of putting double dose in for a couple of things. It's an interesting thought. I could do that.
I mean, for my drug, for Abby, I take it at night and I put out 4 pills in a tray. And I know that if it's, you know, every day I fill the tray, and then before I go to sleep, I make sure that tray is empty.
Peter, another thing that my wife does is just set her phone to go off at a certain time each night.
Yeah.
And that reminds her.
Okay, these are good ideas. Thank you very much.
And I just want to say, I think this is a great conversation, because this applies to so many people. Thank you for bringing it up, Peter.
Yeah.
If anybody else has any great ideas, let us know and we'll make sure they get publicized.
Right.
And Blee is saying, Blee, you're saying they've got something.
They make those week-long pill things with morning, evening, or morning, afternoon, evening, or you can get multiple per day dosing, and that helps remind folks what's been taken and what hasn't. Yeah.
Good. Okay.
I mean, yeah, I have a ritual, but it's more like, you know I've got to take my prednisone in the morning after food. So, or with food. So that I have a ritual that I have to take the prednisone and then I have my coffee and something. But I think having a routine helps.
Yeah, I have a morning routine. I never miss the morning. You know, I get just so involved with something else, watching a movie or going out to dinner or something like that. You know, bam, I go to bed and I forget the whole thing.
Well, we will continue to address this issue. We should collect suggestions and put them into a blog.
Right.
If we can collect the suggestions, I'll get Alexa to write up the blog post. But I need everybody, send me your suggestions and I'll forward them and we'll get a blog post on this because it's really good. It's not just for prostate cancer, for anything.
Right. Okay. Blee, you had something to update us on.
Yeah, hi, thank you. And I have a couple of questions. Haven't been here in a week or two, but so I'm a 61-year-old guy. Had a prostatectomy in early March. Mid-April, I was undetectable PSA and a testosterone of 8191 without any medication. That's just me. And so I had another PSA taken at 6/15, which is two months hence, and it was 0.07. So before it was less than 0.0007, so it's essentially undetectable, and now it's at 0.07. And my testosterone without any medication is at 467, up from 8191. A couple of questions. I have a urologist appointment on the 29th next week, which I anticipate I will begin getting some ADT. I'm just assuming it's Lupron, but I don't have any idea. What is a normal first dose of ADT? Yeah, it seems to me that it's dose dependent, and so you can have 3 month, 4 month, 6 month, whatever. Should I request if and when it's offered, should I request 3 months, 4 months? I don't have a feel for that.
I mean, well, before you get Lupron, you need to get something else in place. You need to have a blocker in place. Right,
what in place?
So Lupron can cause a flare.
I'm assuming Lupron, only assuming it. That's
Right.
all.
So what they would normally do would give you something like Degarelix, which is a blocker for a while, and then Lupron.
Is that right? Okay.
Bicalutamide. You said
Or bicalutamide.
Degarelix. You meant bicalutamide.
Okay. Because I took some days off from work just to adjust. So, okay. That's good to know.
Again, let's just clarify. There are two types of LHRH drug, Lee. There is one that switches off your testosterone right away, and that's called an antagonist.
Okay.
And there's one that forces you to make so much testosterone that the brain says, "I'm overworked. We're overworked here," and it switches it off.
Is that a fact? I'll be darned. Okay.
And that's called an agonist.
Okay.
Okay. And that's what Lupron is. So if you're going to have an agonist, and it could be Lupron, it could be Eligard, it could be Zoladex, if you're going to have any one in that family, you have to take a blocker first.
Okay.
And that blocker usually that they give you is bicalutamide. And what it does is it protects you in case you have some metastasis in a critical place that we haven't seen, and this big jump in testosterone causes the lesion to flare up, and so they give you this blocker to prevent that. Now, some docs forget, and I've seen it maybe a dozen times over the years, and it's not good. So if you have to find out what type of LHRH drug they're going to give you.
Okay.
And if they're going to give you an agonist, you make sure you get that blocker first. If they try to give it you without the blocker, you say no.
Okay.
Now, if they give you a drug, if they give you an antagonist, there's really only a couple available right now. I mean, there are more, but really for prostate cancer, there are only two. One is called Firmagon, which is Degarelix.
Okay.
And if they give you Firmagon for the first shot, you don't need the blocker. And if they give you Firmagon for the first shot and then they switch you, that's okay. You don't have to worry about that. You're okay. They can switch you.
This is the first time I'm going to see this guy, so this is good to know. Thank you.
So find out what he's going to give you. The other is a new drug, which some of the guys on here are using, and the insurance companies seem to be willing to pay for, and it's called Orgovix. Did I pronounce that right?
You know, every time I log on the friggin' internet, all I get are ads for this.
Orgovix. Well, John Ivory is the Orgovix pronunciation, please, and he's gotten me saying it right. It's Relugolix is the other name.
Relugolix.
Yeah, maybe it's Relugolix. I don't know. Anyway, the fact is that you do. It is an option, and it's a pill. Now, the doctors may not be so happy to prescribe that because they're not going to get any money out of it. So, but it's very convenient for you, and it's a good way to go. Okay. Now, if they give you an injection, if they give you a pill's a pill. You take it every day. When you stop taking it, it stops working. We know that's how pills work. If they give you this shot, they're called depot shots, and it gives you a whole bunch of the drug, and it creates like a little matrix, and the drug sits in that matrix, and it slowly comes out. We tend to tell people, don't go more than a 90-day shot to begin with.
Perfect. Thank you very much.
Okay. If they want to give you they might want to give you a 120-day. That would be okay. Don't go for a 6-month shot.
I can't see myself agreeing to that. Yeah. Okay.
All right. So you tell them 90 days, and then you're in it for 90 days. But just if they're giving you a shot that goes for 90 days or 120 days or 180 days, it has to be, that is an agonist, and you have to take bicalutamide before it for
Thank you.
about 10 to 15 days.
Thank you for that very much. So do you assign any significance to this big jump in my total testosterone?
What is your total testosterone?
It's now 467, and 2 months ago it was 8191. No meds.
When you say 8191, you mean 81.91?
81.91, yes.
Okay, so let's just call it 82, because 8191.
Let's call it 82.
We were thinking
Otherwise, my beard would grow fast.
you were bloody Arnold Schwarzenegger there with 9,000 with a 9,000 testosterone.
Oh well, yeah, okay. And I'm sorry, I have a couple of questions, so I'll try not to interject. But yes, it was 82. Now it's 467. Any significance to that?
Well, were you on LHRH before?
Nothing. I've had a prostatectomy. That's it.
Yeah, I think the significance is it was probably a bum test, and we've seen that a few times.
First one, yeah, I was wondering that myself.
Yeah, I mean, you can ask Gary Peters. He just had a crazy
Well,
test.
Mark just unmuted. Mark, what's up? What do you think?
Yeah, it may also be the difference in methodology of measuring, whether it was a liquid chromatography mass spec, LCMS testosterone, or just the EIA test. The regular EIA test, which many docs will order, just is not accurate enough to count on. But 82 doesn't sound right or believable.
So Mark,
thank you very much.
Mark, what about free versus bound? Free versus total?
Yeah.
I'm not sure you gain much. If our testosterons are up, we're going to have very low binding proteins. And in terms of when the testosterone is bound to a protein, if it finds a receptor in the area, it's going to have greater affinity for the testosterone receptor or androgen receptor than it will have for the binding protein. So total testosterone should be sufficient in most cases.
Thank you very much for that. I appreciate it. I only have a couple of more questions. I really would like, I think I would really like the PSMA PET scan. With an undetectable PSA, my doc tried to get me in all kinds of places, no way. But now that I've gone from undetectable to 0.07, does that count as a recurrence? And does that get me into the I don't want this full girdle nuclear bomb radiation. Is it worth waiting for another little bump to get the PSMA?
There's a couple of things here. First of all, you're probably not going to see anything until you get up to 0.65. Now, the guys on the new, there's a new Pylarify drug that was just approved for one of the PSMA tests.
Yes.
In their presentation, they say it works from 0.2, but they really don't have the evidence to support that. It's very sketchy. Okay. And
so there's not enough there to look for. Is that correct?
Hold on a minute. Listen, and then make a note of your questions and come back to me afterwards. Okay. On recurrence, it's usually they only tested down as far as 0.5. For people that didn't have recurrence, they tested down to 0.2. Okay. Now, Mark just put in the chat window, he lit up at 0.3, but that is really unusual. I mean, we've had too many guys in that 0.2 to 0.6 range who have not gotten a result. Some people will, which is why they say it works, but a lot of people won't, And the problem is if you don't light up at 0.2 or 0.3, then you are going to have to go back in again when you get up to about 0.5 or 0.6. And your insurance may not want to approve that, right?
So what I hope, go ahead.
So what I was going to say is that don't even worry about this at this point in time, because at 0.07, at 0.07, you're still probably way too low to show anything.
Okay. Is there benefit in me waiting to have a higher PSA to light up rather than having this carpet bombing radiation?
Okay, so the second thing I would say to you is the carpet bombing radiation, if it were me, that's what I would opt for. Because we know that the guys that get pelvic girdle radiation have much better results. Now, I got the carpet bomb, but I got it initially because I didn't have a radical prostatectomy, but that's what I opted for immediately. All right. It's not as bad as it sounds. There are measures that you can take.
Sounds bad.
The fact is that and we talked about this last week in our call, that pelvic girdle radiation is probably the gold standard. And there are enough articles out there that tell you that for recurrence, you need pelvic girdle radiation and androgen deprivation therapy for enough time. Enough depends on your Gleason score. So with 4+3, which is what you were, you might be able to get away with 9 months of ADT. And if it were me, I wouldn't do anything less than pelvic girdle radiation. Apart from anything else, if your disease comes back, you're going to be saying, oh my gosh, I should have done more radiation in the... And then you'll make yourself crazy on that, Lee. Yeah. That's my view. And we've got 37 other people in this room, or 36, and some of them may disagree.
Yeah,
Gary, you are having... Gary,
when did you have surgery? When was your surgery?
Early March.
And why does the doc want to put you on LHRH drug at a 0.07? I mean, why are they racing to do that right away?
Oh, they wanted to do it a month ago. I had positive margins. I have LVI invasion. I have bladder neck invasion. So they wanted to start me on ADT probably about a month or better ago.
Okay.
My Decipher came back in the high risk area. My first the saliva thing. I know you're running short on time. My first saliva thing. Apparently, I didn't have enough spit, so I have to repeat that thing. But it doesn't sound like that's going to change their recommendation.
Well, talk to your doc. If you put off the LHRH drug for a month or so, which isn't going to hurt you particularly, your PSA might go high enough for to have a PSMA scan that might be effective.
That was my question, but what I'm hearing Rick say is, and I'm okay with competing viewpoints, but what I'm hearing Rick say is, go for it. So that's not my inclination, but if that's where the numbers lie, that's fine. I don't know the numbers.
Look, here's my thinking. We know you had bladder neck involvement. We know you had SVI. We don't need to do the scan to know where the cancer is. A lot of times we don't know where that cancer is, and we want to find out where the cancer's coming from. In your case, through the PSA, through the RP, the radical prostatectomy, we know it's there.
But do you know where it's not?
Well, but we need to treat it.
Okay.
And the chances are that you have metastasis throughout your pelvic lymph nodes.
Yeah.
And we got to get to that and nail it sooner rather than later. You know, the problem is, and I see it a lot with people on this call and with a lot of advocates. There's new technology and they say, oh, well, we got to use the technology and we can find this out and we can find, hey, you don't have to be a brain surgeon to figure it out with Blee Moffat. Unfortunately, you got cancer that's in there and we didn't get it all with the surgery. So we know what we got to do. We got to go to the next step, which is put you on ADT for 9 months at least. I probably would even stay on longer, even though you're only 4+3. And we've got to give you radiation. And I don't think that there's any question in my mind that for me, I would get the whole pelvic girdle done. Yeah, can we let it go up? Yeah, we can let it go up, but maybe it'll spread a little more. No, we need to get in and we need to nail it because we know it's there.
Right.
That's my thinking.
So,
I appreciate that.
so I think you got to have a conversation. But I think you want to clobber this.
Yeah, I think you mentioned you're going to go see your urologist. Is that your doctor?
Well, I don't have anybody right now steering my ship. I do not want to go back to the fellow that did the surgery because I think his decision making was flawed. So I have a new guy. So I don't have.
Let's just come back because I've got my notes from last time. You were seeing a radiation oncologist in Richmond. We suggested that you go see Fleming in Norfolk because he is a GU med. He is a GU med onc.
Right.
And we had this conversation about you needing to see a GU med onc. And the other thing that we suggested is maybe seeing Collins as a radiation oncologist because he's top drawer.
My rad onc is in Charlottesville. I gave up the Richmond folks. Very happy with the Charlottesville, Sylvia Hendricks. Very, very happy. Seeing a new urologist because I'm done with the Richmond folks. We called Fleming, and I'm sorry. We called Fleming, tried to get in, and it was like so far in the future that it was impractical.
Well, yes and no. Take the appointment as soon as you can get it, and maybe we'll get you to somewhere else in between.
Oh, okay.
So, you know, Fleming is convenient for you. If you wanted a quicker appointment and you want to bring in somebody as your quarterback and stay with them, there are other options in the DMV.
There certainly are.
Every time I say that, I'm thinking the Department of Motor Vehicles, but no, the Delaware, Maryland, Virginia.
I live here and I still think of it as Department of Motor Vehicles.
There you go. But you know, you know that you do need a GU med onc on your team, Blee. You definitely do.
At this point, yes.
Okay.
But you know, it doesn't hurt to be going with your Charlottesville, the rad onc in Charlottesville, and starting this treatment. I mean, who's going to give you the shots? The rad onc?
The oncologist, I was thinking. Or
yeah,
rather,
but you don't have an oncologist.
Urologist, I'm sorry.
That's not their job.
No,
the urologists are surgeons.
That's not their job. Either the rad onc should give it to you, or you don't get into bed with a urologist for these shots. All right? Because you'll never get out from under them, because then they've got you as their cash cow and they should not be giving you this treatment.
So,
okay,
guys, I do want to, we're getting close to the witching hour, and we have one more person.
I'm good. You've given me tons. Thank you very much.
So we have
here's what I want to say. Hold on. If we've only got one more, that's great. So we're not going to go too far over. if you need the name of a radiation, if you need the name of a GU medical oncologist, there is a guy at University of Virginia. I can tell you, I'll tell you his name right now. Jerry, we love Jerry Deans, and you've talked to Jerry. Jerry is not a big fan of this guy, but you know, doesn't hurt for you to go talk to him. His name is Dreiser, Dreiser.
Dreiser.
Dreiser. Okay. He's at UVA, which is relatively convenient.
Yeah,
Would I
very.
recommend him? No, not on the basis of what Jerry told me, but he's there. I want you to know.
It's a start. Yeah.
The guy in Norfolk, whatever his name is,
Fleming, yeah.
whatever I just said to you, he is, you know, we've had people go see him. They seem to like him. So, you know, that's a possibility.
Okay.
If not, there are a couple of people in DC, or you've got to go to Duke, or you've got to go to Hopkins in Baltimore.
I don't have a problem. If it's okay, I'll drop you a note and we'll get all that together.
We can certainly, right, if you need local stuff, we can get you.
Okay. Thank you very much for your time.
Yeah, if it were me, I probably would go to Hopkins, to be honest.
Okay. I already go to them for my eyes, so I'm good.
Okay.
But that's all the way to Baltimore.
It's a short train ride, 3 hours, no problem.
Right. Okay.
And Hopkins will probably have the PSMA PYL scan probably in July. That's what they're estimating right now.
Yeah, they are. But again, you know, don't confuse the issue. This guy he knows what he's got to do. He knows what he's got to do. He's just got to do it.
But I would get a GU Med Onc sooner to sort of make sure everything hangs together.
Okay. Thank you very much.
Okay. Kang, we're waiting for your update.
Okay, yes, I went to see, in the morning I went to see a medical oncologist. In the PM, I saw the radio oncologist about treating the primary tumor with the radiotherapy. Well, I wasn't sure about the risk and reward issue, and my medical oncologist seems to get it, and he said, well, if I were you, I would go ahead I would go with it. Okay, I was happy because Rick mentioned about SBRT, and so I went to see my radio oncologist in the afternoon, and well, the first the fellow doctor mentioned the possibility of IMRT, and eventually the doctor himself came in, said they can probably only do 3D conformative radiotherapy. I don't know what that is. Is that something ancient or?
Yes.
It is ancient. That's my guess.
Where are you going? Where are you? Where is this? Where are you seeing them?
It's his name is Richard G. Stock. He's affiliated with Mount Sinai. The reason he was saying that is, in your case, SBRT is not an option because it's not local. It's metastasized. So the insurance, just my insurance, it probably has something to do with my insurance. It's New York Medicaid. Probably won't approve of that. Not even the 20 session of IMRT. So he mentioned something about 3D conformative, 10 session of it. He said they probably will approve of that. He can probably just to increase the dosage. And I asked him, is that a big difference between this 3D conformative treatment with MRT or SBRT. He said, no, the outcome are pretty close. Well, because I don't know enough, but I can remember the outcome are pretty close. It is just the my status of Medicaid. They will have a problem with the stuff he would really wanted to give it to me. He said, well, from what I know, I really want to try this on for you, but your Medicaid status probably just won't approve it. And so it left with my option, which is the only one, is a 3D conformative. But my medical doctor said I don't need to make a decision too fast, too soon, because I have time. I have 3 months or 6 months. I don't know what that means. Maybe it's just because I'm in a stable state of disease control or management. Yeah, I mean, yeah.
Can I just clarify? So your GU Medonc agrees that it thinks that it's worthwhile radiating the prostate. Now, is he also saying that he thinks you should radiate above the prostate, the pelvic lymph nodes? Are they suggesting that too?
The medical oncologist didn't have too much details. He just said, go ahead and do the radiotherapy.
Okay.
He saw my confusion. He said if he were me, he would do it.
Okay. So what is the field? What field of radiation does the RO want to do? Does the radiation oncologist want to do?
Probably the primary tumor. The fellow doctor, he's spent more time with me. He mentioned the 20 session of IMRT.
Right. What is the field? Just the primary tumor, or do they want to radiate above the primary tumor to the pelvic?
lymph node area? I mean.
Okay. So let me explain something. Okay. The SBRT, this is separate from the insurance, whether it covers it or it doesn't cover it.
Okay.
The SBRT is probably the best thing to do for the prostate gland. That's what Herb just did. Okay. Now, a lot of doctors won't radiate the lymph nodes for a metastatic patient. I'm not really sure why, but I don't think there's been any trials. To me, it makes sense, but it's maybe a do no harm thing. That said, it's very hard to get that done with SBRT. There's only a few places that do it because it's very new technology. The place where Dennis McGuire is treated, they have published some information on using SBRT in small fractions, but it is very hard to do. So realistically, you're going to have to go through IMRT for the pelvic lymph nodes. I would think that your insurance will cover IMRT for the pelvic lymph nodes because that is very basic technology today. I'm not exactly sure when they talk about 3D conformal what they want to do. If it has to be guided. If it's not guided, then you can appeal and you can get it because at a minimum you're entitled to guided radiation.
Which is 3D conformal. You can still
I don't know if the 3D conformal is or it isn't. It's one of these terms where, and maybe somebody else can clarify for this on the call that maybe somebody knows. but the 3D conformal is an old term in radiation. And I mean, and so when you talk 3D conformal, that isn't even IMRT. And IMRT is the absolute minimum that you want to go with.
Okay.
Okay. I'm just looking to see if I've got the pamphlet here. I don't. I can't find it offhand. So, but I don't know what 3D conformal means. You need to ask him what exactly is the equipment. Is it going to be guided? If it is going to be guided, how are you going to guide it? With gold fiduciaries, or with transponders, or are you going to take you're going to do an MRI before each treatment, or a CT scan before each treatment and set it according to that? There's a lot of technology in here. I'm not the best one to be talking to you, but I can tell you, I don't think 3D conformal is up to date. Len, do you know?
I know that 3D conformal preceded IMRT, and it's definitely inferior, certainly with regard to side effects. It's not as accurate. You'll have collateral damage with the 3D conformal. So Kang, I'm telling you, don't do it.
Okay, I hear you, Len. Thanks.
Yeah, sure.
Right, and Kang, I think that you'll find, even with your New York Medicaid, that they would approve IMRT. Now,
I hear you.
if you have to have IMRT to the prostate, it's not the end of the world.
Okay, is that the carpet bombing? I mean, is that the words for it? I heard you guys saying that word, using that word earlier.
Well, that's the word that Lee used. I would not call it Lee was talking about the radiation to the lymph nodes, is what he characterized as carpet bombing. I personally would not.
Okay.
I think that's the gold standard. And so, but as far as the prostate is concerned, if you can get SBRT, I'd go for it.
Yeah, it seems to me, at least at Mount Sinai, it seems out of the picture. I mean, it's not. I use the SBRT with my medical oncologist. He said your insurance probably won't approve it. And then the fellow doctor, the oncologist office said, well, you are metastasized, you are not local, so that won't be your case. And the final doctor, Dr. Stock, even said MRT is not even going to be approved because they have a case like that, like my case.
Well, I think then you've got to start advocating, because IMRT has to be approved for, I mean, IMRT is the least that can be approved, and it should be approved, and IMRT should be approved at least for the prostate.
Then why wouldn't want to do it? And is this a difference of 20 sessions or 10 sessions?
It's the difference between 20 sessions and 5 sessions.
Right.
Or 4 sessions.
Right. I mean, he was saying 3D conformal.
Okay, 3D conformal technology.
And then
I would be afraid of 3D conformal.
I hear. Right.
It basically means that they're using they're going to catch more than you need to.
I'm so glad I bring this up.
But maybe
today.
it's time to go talk to a different radiation oncologist.
Okay. Okay. Thanks for the idea. I'll try to figure out a way to see how to do it. Should I discuss that with my medical oncologist?
Yes.
Yeah, he mentioned IMRT. He mentioned IMRT. My medical oncologist is just the radio oncologist didn't even think that's a possibility. So he brought it up 3D conformative.
Okay, well, you know, I don't know why he doesn't, and I don't know enough. This is an insurance issue. From a medical standpoint, you don't want anything less than, I would say IMGT, I prefer to call it, image modulated guided therapy.
Okay.
So you, sorry, I'm confusing you. Image guided radiation therapy, IGRT, rather than IMRT. IGRT. You don't want anything less than IGRT. And I think that you've got to find somebody who's willing to advocate for you to get that from New York Medicaid. The problem is New York Medicaid is New York Medicaid, and I don't know whether you'll get it. And I don't have experience with New York Medicaid. You know, Larry Fish has left the call now. He may know more about New York Medicaid. Or, you know, some of the other guys who have experience with in New York.
It's quite a navigation, I would have to say. Yeah. I guess I will bring it up with my medical oncologist, because IMRT is what he mentioned. And then the radio oncologist said, or similar case like mine, the insurance didn't even approve IMRT. And so he brought up the 3D. And then today I'm happy I brought it up, so I won't go that way for the 3D.
You do need some radiation though. So
I'll figure out, or I'll see what I can do to maybe try different radio oncologists to see if. But if I go to different institutions, do I need to discuss it with my medical oncologist from Mount Sinai? I don't. I just.
No, you can say, look, this guy is not giving. I got to talk to another radiation oncologist elsewhere because this guy isn't fighting for me.
Okay. I hear the words fighting. Okay, that's probably the. I don't think he want to bother. That's how I felt. He didn't want to bother.
And sounds right. I mean, you know, I would say go down to either go to MSKCC and speak to one of the guys there. We know a bunch of guys there, and we can give you names, or go over to Weill Cornell. We've got some experience with some of the people at Weill Cornell.
Okay.
Joe Gallo, you know some of the names there, and some of those radiation oncologists at Weill, and at I know a couple of MSKCC. Any names?
I'm trying to see if I can draw back on some of the names, but I may be able to get some from Elliot.
Right, Elliot. Yeah,
because he was both at MSK and at Weill Cornell.
Hank, where do you live?
I live in Flushing, but I use public transportation, or I could, you know, particular case, I could call a cab.
The one guy at Weill Cornell that is the premier guy is Margulies, Dan Margulies.
How do you spell the name? Or
I think it's
Margolies.
Yeah.
Okay. All right. Margulies. Okay.
Yeah, but he's really more. He is a radiation oncologist, but he's really more into sort of scanning and MRIs and that end, as opposed to the treatment. But you know, we could, one of us could write to him, Elliot or one of the other guys, or somebody could write to him and get a name for you. But there's a, you know, that I would say the Weill Cornell or Memorial Sloan Kettering.
Okay.
Len, do you have thoughts on this? I mean, you know the New York market.
Yeah, there's at MSK, there's Michael Zalewski, Zelefsky.
Right.
And another one is Marissa Kohlmeyer.
Oh, yes.
How do you spell Komeyer? Komeyer.
I believe it's K-O.
HL.
HLMEIER.
Yeah, I think that's right. And the guys seem to really like her. Zalewski is the top guy there, and he's very good. He's the head guy. And Kohlmeyer gets rave reviews.
Okay. Zalewski spells like a Zellessky.
Yeah, EF. F as in Freddy, SKY. Yeah.
Okay. Okay. Yeah, I might have to switch my New York Medicaid, which I don't know. I will look into it because with the emblem I have now, I won't be able to seeking treatment in MSK, but with Empire Blue Cross and Blue Shields, I could. So that's a possibility.
Okay.
Yeah.
Ken, we got to move
Yeah.
on. We never checked with
Well,
Ken.
I think
We never checked with Ken, Herb, and Ken's back.
Is Ken back?
Yes.
I was told he was asleep.
Ken, are you asleep, Ken?
You're here. No,
No.
He just unmuted.
I wanted to say, King, let's chat this week or next week. I mean, yeah, you definitely need to get some other team or some other group in regards to radiation of the gland. So, her mind was only at the time because it sounded like in the very beginning you were going to have a lot of guys chatting, but it seems like we're running over. I don't really have that much to say.
Well,
So,
I mean, it's your time now, or we can wait till next week.
yeah, next week I'll have labs. I'm getting my 19th round of chemo this Friday,
Wow.
so next I'll have more info.
Okay.
I haven't found any, unfortunately, and I've been looking for them.
Okay.
Okay.
So you don't want to update it now, Ken? I'll talk to you tomorrow.
Right. Okay. I have a question for you guys. I need an answer.
Yeah.
Is alcohol considered food?
No.
Where's Jimmy? Jimmy left already.
Comes from grain.
I mean, if you're not supposed to have, if you're taking Abby and you can't eat 2 hours before, you need 2 hours of no food. Is alcohol part of that?
Okay, so here's where it goes, Professor, and you're going to be able to hopefully unravel this from what I'm going to say. It's a function of keeping your liver inactive, I think, and since and I suspect that since alcohol is passed through the liver, it probably is included.
Drats, I need a drink.
Can I have what? Could I have yours? I'll have one for you.
Okay, guys. We will. Anybody else have anything they want to add before we conclude? All right.
No, you did it. Well done.
Jake,
marathon job. You did fantastic, Herb. Fantastic.
Actually, I actually was recorded saying, I was recorded saying that, actually. Jake, you need to edit the recording.
Yeah, you can negotiate that with Jake. I'm not doing that.
Send a check, Herb.
All right,
Okay,
guys.
stop recording.
Just one very quick thing to say is we don't have a meeting next week, so we will see you in 2 weeks. Okay.
Right.
All right.
Bye all.